Dr. Pratibha, Dr. Pratibha is also Dr. Debarun. Please ask. Bharati Balachandran, madam. Yeah.
Good evening.
Madam, you're working in Mumbai?
No, sir, in Bangalore, St. John's Medical College.
Oh, yeah. Okay. I came to St. John's that day.
Yeah.
Did we meet? No.
No, sir.
I just came and saw your NICU, went inside, have a big round of whole of St. John's. Lovely place.
Okay, sir.
Madam has joined. Madam has joined.
Okay, so
Ma'am, unmute kar lijiye.
Meena ma'am.
Yes.
Ma'am, actually Ashok Derari sir, he's asking on the mentors group, on mentors NICU group that he's not able to log in. He's not able to join the meeting.
उनको फैकल्टी वाला लिंक दो ना.
फैकल्टी का दे दो.
अच्छा, ठीक है sir.
Hello.
Good evening, ma'am.
Good evening, Meena. How are you? From
good.
Andaman and Nicobar, I heard.
Yeah, just now.
Andaman.
2 दिन पहले ही वापस आई हूँ.
अच्छा, वापस आ गए हो?
हाँ.
So, hello everyone who all have joined.
Good evening,
Nice.
ma'am. Hello,
Good
ma'am.
evening. Good
Good
evening.
evening, madam.
Hello, good evening, ma'am. How are you, ma'am?
Good evening. Good evening. All good. कैसे हो गीतांजलि?
Good evening, ma'am. Good
evening,
evening,
sir.
ma'am.
So,
Good.
are we live now or we have to wait?
We are live now, ma'am.
Okay,
Shall we start?
Yeah.
Yeah.
Ma'am, with your permission, can we start the session? Sushma,
Yeah,
ma'am?
yeah. Please do. Please do. Please do.
Okay.
So, good evening and a warm welcome to all the dignitaries present here. I'm Sreushi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clanet serves as the digital partner for this event hosted by National Neonatology Forum, and the focus of today's session is International Nurse Day, Our Nurses, Our Future, the economic power of care. So let's begin today's session, for which I would like to invite Dr. Meena Joshi ma'am to take over. Over to you, ma'am.
Thank you. Good evening, everyone. On
Namaskar.
behalf of
Dr. Devari has joined.
good evening, sir. Oh, and welcome, sir, to our this session. And can we start now? Okay. So good evening, everyone. On behalf of NNF and IANN, I'm delighted to welcome you to our Nurses Day celebration. This year's theme, Our Nurses, Our Future, the economic power of care, highlights the pivotal role nurses play in shaping the future of healthcare and the economy. From neonatal nursing to geriatric nursing, nurses are at the forefront of providing care to the patients. Investing in newborn and neonatal nursing is not just a moral imperative, but also an economic driver. The care provided to the newborn and their families sets the foundation for lifelong health and well-being. By supporting neonatal nurses with resources, education, and recognition, we can ensure better outcome for our youngest patient and their families. On this day, I would like to extend our heartfelt gratitude to our esteemed guest, Dr. Sushma Nangia, President NNF, Ms. Susie Sarah John, Secretary IANN, and Dr. Surinder Bisht, Secretary NNF, for joining us today. And I know that we don't have to say that Dr. Ashok Devari, sir, for joining us today. And I just want to thank NNF for their unwavering support of nurses and neonatal care. So without any further delay, let us continue to celebrate Nurses Week and honor the incredible work of nurses around the world. So with your permission, ma'am, now I want to hand over the floor to Dr. Kavita Shrikumar to begin the session. Dr. Kavita Shrikumar.
Good evening everyone, and a warm welcome to this session. Today is International Nurses Day, and coincidentally it's also Mother's Day. So happy Nurses Day to all the nursing colleagues, and also a happy Mother's Day to everyone. Nursing is a profession which is one of the most a blessed profession, I must say, because they care for patients like no other healthcare professionals. And if you look at neonatal nurses, they look after the littlest patients, the smallest patients. But I think to look after the smallest patients, we need the biggest heart, because we look after not only of the newborns, we look after the families as well. I would now begin the session by inviting Madam Sushma, who is the president of National Neonatology Forum, to say a few words on this occasion. Madam Sushma.
Yeah, sure. Good evening, everyone. And it's a pleasure that we all have gathered virtually to celebrate the International Nurses Day and follow on with the week. So today, as Kavita has said, Surinder also mentioned, and Meena also spoke, we have Dr. Derari with us. Good evening, sir. May I request everyone to kindly mute except the one who's speaking, because it does disturb. So welcome, sir, and welcome everyone who's here. And needless to say that nurses are the backbone of healthcare. There is no doubt in that. But it is even more so in newborn care. And I believe that newborn nurseries have been named as nursery because it is majorly the contribution of nurses in the care of newborn, who double up not only as healthcare workers but also as compassionate human beings, almost being second mother to the baby while the baby is in the NICU. So nurses have a very, very important role to play in neonatal care. And wherever nurses are compassionate and they are taking care of the baby, the mothers feel much more home in those NICUs, and they are caring as well as providing more care to their own babies, because the nurses provide that umbrella under which they can, without fear, without any kind of scare, work and take care of their babies. And I have always believed that we as doctors only come and see the baby as a snapshot. So we are there for our rounds or for our assessment. It's just a snapshot, very similar to a photograph being taken or a picture being taken, which may or may not be absolutely appropriate to capture what is happening. But the nurses there are like a video. So it's like a video, they are constantly there. They are looking after the baby for a long duration. And all of us depend on the nurses in terms of how the baby is doing, take the next step or to take the next decision. So, I mean, I cannot reiterate the fact that nurses are very, very important in healthcare, but absolutely, I mean, inseparable from newborn care. So this is a very opportune moment that all of us have gathered here. So I request Dr. Kavita and the others, Meena, kindly take on and let's go through the proceedings of the day.
Thank you, ma'am. Thank you for those words. And I know Madam Sushma always inspires us to consider nurses as our colleagues. I've worked with her, and she always says nurses should be given priority. Their needs should be taken care of. Moving on, I would like to now invite Dr. Surinder Singh Bisht, Secretary NNF, who is a guest of honor for this session, to say a few words on behalf of Nurses Day.
Thank you, Dr. Kavita. So I'm the host only. So on behalf of Secretary National Neonatology Forum, I extend my heartfelt gratitude to all those who are involved in organizing, conceptualizing, and making it happen. I'm so grateful to all those who have joined today. I'm so thankful for all of the nurses fraternity and the doctors from across the country. And we have representations from all the countries, and we could make that program happen from all parts, be it Mumbai, Sneha Patil, be it Jammu, from Kolkata, from Chennai. So we have people, and Bangalore, and from Delhi, and from everywhere we have people who have taken up the responsibility of making this program a success, as you rightly said. So this year's theme is our nurses, our future, the economic power of care. And rightly so, and I would urge everyone to look into this. The nurses, as Madam said, are the backbone of care. But not only the backbone. I think Madam has put them not, you said we give them a priority. Madam has put them at a higher pedestal. Madam has said they are more than equal to us. So they, in fact, the nurses are more than equal to the doctors. In fact, we both as a team make a difference in the quality of care which we provide to our patients. And this is the theme this year, that if you improve the nurses ratio, if you improve the nurses quality, the quality of care improves, and that actually can improve the GDP by 8% or so, or can make the economy improve better by $12 trillion, or take the economy to around $12 trillion. So the economy of investing in nurses, Dr. Susi Shara John, Madam. So actually, I really want all of you to reiterate, emphasize that investing in hiring nurses, investing in having nurses around, investing in training nurses, educating nurses, providing them opportunities to grow is not an investment. It is actually you will reap the benefits to a much more extent later, and not only in terms of the money saved or the quality of saved, the survival saved, the intact survival, mainly in cases of newborns when we are saving babies. So it will be an intact survival of babies if the quality of care provided to the nurses. Right now, our nurses across countries are overburdened, and we may worship them. We may say you are doing a great job. We may say anything like that. But in heart of heart, we know our nurses are burdened with work. They don't get to eat. They don't get to any me time. They don't get to just sit around. They are just running around, and plus they always have the fear and guilt of any baby not doing well. So they're constant under the pressures, and still, despite the pressures, our nurses across the country are doing well. And fortunately, our forefathers or grandmasters of NNF always felt nurses are equal partners. That is why they were given equal opportunity in National Radiology Forum in those days. And we are the organization in one of the meetings in where for Sankalp, UNICEF, and they were saying we should bring nurses together. I said they are a part of us. Out of 10,000, 3,000, 4,000 are nurses only. So we are not different from nurses. NNF means nurses, doctors, physiotherapists, occupational therapists, pediatric surgeons, all who are involved in care of newborn care, to work together in saving newborns. Thank you. And I'm really thankful to Dr. Devrari sir for guiding us always, and his emphasis. And sir जब round लेते हैं, जब sir बताते हैं, और हमें सिखाया सर ने, यही सिखाया कि, and thankfully मुझे तो मीना जोशी जी थी एम्स के अंदर जो सिखाती थी, and she was the one who was teaching me all that time. Thank you, sir. Thank you, Meena.
Thank you, Dr. Bisht. I would now invite Miss Susie Sarah John. She's a secretary of Indian Association of Neonatal Nurses. IANN is doing significant work in training and promoting the neonatal nursing in India. It is not only taking care of training, but it also takes care of the neonatal needs, the needs of nurses in the country. I would now invite Susie Sarah John ma'am to please say a few words on this occasion.
Good evening, everyone. At the onset, I would like to thank Dr. Sushma Nangya, President, NNF, and Dr. Bisht, Secretary, NNF, for giving me this opportunity on this, the International Nurses Day. On this International Nurses Day, we honor the invaluable contribution of nurses worldwide. This year's theme, Our Nurses, Our Future. The economic power of care holds particular significance, especially in our country. Nurses are the backbone of healthcare system, providing compassionate care and expertise across diverse settings. They are widely trusted professionals, recognized and appreciated by patients, their families, and communities for their crucial role in healthcare. However, our nurses needs empowerment. Government should fully acknowledge their extensive value and aim to have sufficient nurses in our healthcare system, particularly in the neonatal wards and in the nursery, or create enough new registered nurses to ensure universal health coverage and essential benefits for everyone. The nursing shortage is hindering both health and wealth of our country. Governments must invest in nursing to see significant reward in return. Strategic investment in nursing is crucial for rebuilding and fortifying healthcare systems and economies, contributing to the delivery of sustainable development goals. The International Nurses Day theme highlights the economic impact of nursing, showing how enhancing the profession can drive significant improvements. Allowing nurses autonomy in practice, including advanced practice nurses, will improve health system efficiency and effectiveness. Nursing leaders play a crucial role in harnessing nurses' economic power through strategic planning, resource allocation, quality improvement, financial management, advocacy, influence through education, training, mentoring, and assertiveness. The nurse practitioner, that is the independent nurse practitioners cadre in India, will play a vital role in bridging healthcare gaps and improving access to quality care. The independent nurse practitioners will carry out tasks in primary healthcare, collaborative practice, specialized care, patient advocacy, health promotion, disease prevention, leadership, and education. The professional organizations must develop the independent nurse practitioner syllabi and advocate for independent nurse practitioner policy creation. The IANN, under the leadership of Dr. Manju Vatsa, founder president, and Dr. Jyoti Sarin, president, has been instrumental in preparing a curriculum for independent nurse practitioners in neonatal nursing, which has been accepted by the INC, and this has been forwarded to the Ministry of Health and Family Welfare and is in the process of getting accepted. If it gets accepted, then we have to work on building a cadre for the independent nurse practitioner neonatology. In conclusion, let us recognize and celebrate the economic power of care embodied by our nurses on this International Day. They are not just caregivers, but also catalysts for a healthier and more prosperous future. Thank you.
Thank you, Susie ma'am, for highlighting all the relevant points in the roles of nurses and giving us a good news that nursing practitioners course is going to get accepted. So that is, I think, very much needed in our country today. In any session when Deorari sir joins, it is always a pleasure to have him on board. Sir, could you please say a few words on this occasion to our nurses?
Sir has to give words of blessings to all of us.
Yes,
His
because
constant, he's the mentor to us. He's the overarching guiding spirit for NNF for so many years, and we really want him to guide us.
And he has always pointed out that we should create nursing champions. Those are the ones who are actually going to decrease neonatal mortality.
And all of them are here today.
Yes.
Thank you, Kavita. So once again, best wishes on this International Nurses Day. And I strongly believe you are the frontline people who are involved in cares of the mothers and the babies. And your role is very, very crucial because you connect with the families and in a compassionate behavior. You are all very dedicated, very sensitive individuals, and always look for how we can do better and better in clinical care. My best wishes to all of you on this International Nurses Day. And I'm very sure all the neonatologists, all the pediatricians and medical officers will work very, very closely with you for making important contribution in lives of the mothers and newborn babies. Thank you. Thank you, Dr. Bisht. Sushma and Kavita, Meena Joshi, Susie, and everyone who has joined on this web call. Thank you so much.
Thank you so
Thank you,
much,
sir.
Dr. Devrari, for being present and encouraging us throughout.
Thank you, Madam Sushma, Dr. Bisht, Susie ma'am, and Devrari sir for all the words of wisdom. Now we shall actually move on to the theoretical session, the academic session of the day. I would like to welcome Meena ma'am again to introduce the first speaker for the session. So we are going to cover some of the very current trending topics in neonatal nursing today. The first session is going to be on golden hour management. Madam Meena, can you please introduce the speaker, Dr. Shilpi Sarkar?
It's my pleasure to introduce Shilpi, and she has done her master's from AIMS College of Nursing, and then she joined a private institution, Hamdard, and working as a lecturer there. And she has many publications, and she has contributed in writing many papers also. So welcome to the session, Shilpi, and you can start the session.
Dr. Bharti is the chairperson for this session. Dr. Bharti Balchandar is the associate professor in Department of Neonatology, St. John's Medical College, Bangalore. Welcome to both Dr. Shilpi and Dr. Bharti. Dr. Shilpi, you can start.
Good evening, everyone. First and foremost, I would like to express my gratitude for giving me this opportunity to take this important session, which is golden hour management for the neonates. It is very essential, and we are going to discuss. So in this session, we are going to cover about the preterm birth, the major cause of neonatal mortality, long-term complications in the preterm babies, concerns in the preterm babies, what is the meaning of golden hour, and the components or interventions for term and preterm neonates in the golden hour management. So this slide shows the causes of neonatal deaths in India, and it shows that the major chunk of the mortality in the neonates is because of the preterm and the low birth weight babies and the complications associated with that. And the other causes are, we are managing other causes, and there is a recent trend which has shown that the MMR, IMR has reduced, but the preterm part, it is not that much affected. The contribution of the preterm birth causing neonatal mortality is not changed significantly. So this is another study which shows the other causes of infant deaths in India. And this also shows that the prematurity and low birth weight is one of the major cause of neonatal mortality. So we need to manage premature babies and the low birth weight babies. And then the studies have shown, one study in the Norway that has shown that the babies who are born preterm, the long-term complications are also there. And it has been found that the children who were born preterm, they were suffering from cerebral palsy, mental retardation, disorders of psychological development, behavior, emotions, blindness, hearing loss, epilepsy. These all are because of the lack of oxygen supply to the brain, and the complications are then this all. Now we will discuss about why the preterm babies, what are the concerns in the preterm babies. So preterm babies are more likely to undergo hypothermia because of their large body surface area, their thin skin, there is a lack of body fat, and the hypotension, hypoglycemia because of various changes, and the immature metabolic system and the hormonal regulatory system, they undergo hypoglycemia, hypoxia and hyperoxia. They are at risk for both hypoxia and hyperoxia. Hypoxia because they do not breathe at the time of birth, and there is a delayed, if there is delayed oxygenation and ventilation of the lung that causes hypoxia and hyperoxia if we intend to give the oxygen in a proportion that causes a hyperoxia and the related complications. Then respiratory failure, intraventricular hemorrhage because of the increased because of the stress and because of the increased blood supply to the brain. The capillaries in the brain are very fragile and they are likely to get ruptured. Then chronic lung disease, necrotizing enterocolitis, because the babies, if they are not taking, and if there is no function of colon and intestine for some period of time, that results in necrotizing enterocolitis and retinopathy of prematurity because of the oxygen administration. Now we will focus upon the first hour of life, which is a transition period of the newborn from fetal to ex utero life. So this is the most crucial time where so many changes are taking place, structure and functional changes. So the baby has to adapt in the ex utero life. Now the meaning of the golden hour, the first hour. So this is the origin of this golden hour. It is adapted from trauma management, and which says that the trauma patients, they need, if the interventions are given, the resuscitative interventions are given very fast in a 1 hour, then there is a miraculous effect in the life of the trauma patients. So considering that factor, and there is a golden hour. So what is that? That is the initiation of complex set of tasks and procedures which must be performed in a systematic, sequential and efficient manner within a short time period, that is within 1 hour, to stabilize the neonate, to rapidly stabilize the neonate. Practicing all the evidence-based intervention in this 1 hour, we will practice only evidence-based intervention. We will not waste our time in the intervention which is not having any evidence-based findings. For the term and the preterm neonates, the golden hour management can have a significant impact on the neonatal outcomes. It has been proved in various research studies. There are various interventions which are included in the golden hour interventions, like the delayed cord clamping. Before that, we will talk about the antenatal counseling and the team building, the team briefing. Before birth of the baby itself, we have to assess the risk and the potential problems that the neonate might develop after birth. So we have to prepare ourselves, our team members, we have to brief the team, and also we have to counsel the parents. We are going to discuss each one, so we will just see what are the interventions broadly. Then the other one is the give support to the respiratory system, give support to cardiovascular system. So we are supporting the cardiovascular system, respiratory system, and also we are giving support to the nutritional care. And then there is a delayed cord clamping. And the most important part is the prevention of nosocomial infection. We have to ensure that, and also keeping the records. All the necessary record has to be kept, and we have to prevent the baby from hypothermia, and we have to give the therapeutic interventions in all the care aspects. So antenatal counseling, in the antenatal counseling, we are assessing the risk by taking the history of the patient, of the mother, antenatal mother, and checking for the likely risk of the high risk newborn, like the baby may need, we have to counsel the parents regarding that, if the baby might need hospitalization in the NICU, or the baby need blood transfusion or some interventions. We have to prepare the baby. Sometimes the baby need to be shifted to another hospital. So, and the care, what type of care the parents can expect from the hospital and how they can contribute. So communicate, and then the communication of the risk is also very important. We have to give the clear image in the parents, and also if possible, we can give antenatal steroids and antenatal magnesium sulfate if we are expecting the baby is going to deliver before 34 weeks of gestation, it will increase the lung maturity. Then we have to do team briefing. In the team briefing, there should be one unity of command. So team leader is needed for that, who will be delegating the responsibilities to each team member. So there is no confusion when the baby arrives. So everyone knows what is their responsibility, not after the birth, but before itself. If they have to do any preparation, they can do it beforehand. And there is no duplication and waste of manpower in this delegation of responsibility. So this is a very important step. And then effective communication should be there. Then team briefing, like if it happens, then what is the next step can be done. So all aspect has to be detailed in brief to the team members. So like this is a this table shows the like timely management and what all actions will be taken by the team leader and the different members in the before birth, in the delivery room, and in the first 10 minutes, after 10 minutes. So in first 60 minutes, what all type of intervention can be done. Like for nurses, it is like increasing the temperature of the labor room to make it between 25 to 28 degrees Celsius, and then radiant warmer should be kept on, then putting the warm blankets, ensuring kangaroo boards are available, and then also ensuring that if the other this is done beforehand. After that one, once the baby is delivered, then accordingly different managements are there. Similarly for other members, like preparing for admission in the NICU, and then preparing the parents, counseling the parents, and the other members can do the preparation for setting the equipments, and the other checking the equipments functionality, and making sure that all equipments and drugs are available. So the first step we are going to discuss about in the intervention in the golden hour is the delayed cord clamping. In this figure, this diagram, we can see the baby. If the baby is born and the near about 110 to 120 ml per kg of body weight is always there in the placenta, which is there for the circulation. So if there is an immediate cord clamping, then this much amount of blood is the baby is deprived of this much of amount of blood. So if there is no emergency, then we can delay the cord clamping to first 3 minutes. It will ensure that the 80% of the blood is transfused to the baby back. And if the baby is having complications and it is difficult we have to do the cord clamping and cutting of the cord, then it can be at least 30 seconds, it should be delayed. Cord milking, why the cord milking is not practiced here? Because it increases the risk of intraventricular hemorrhage, because there is a sudden gush of blood which increases the blood supply to the brain, and the capillaries are likely to get ruptured. Next intervention is giving respiratory support, and it has been found in various studies that the babies who are born with their term gestation after 35 weeks of gestation, we may say, so 21% of oxygen, that is a room air, is sufficient in initial steps and oxygen resuscitation. And if the baby is preterm, at least 30% of oxygen FiO2 can be administered. And we have to ensure that we are giving heated, humidified, blended oxygen to the baby, so that we can ensure that there is no mucosal damage and because of the dry oxygen. Then CPAP is another way which is non-invasive and very effective in reducing the need for the IMV, that is intermittent mandatory ventilation, and the need for intubation. T-piece resuscitation is another way for the non-invasive ventilation. Then early rescue surfactants can be administered if needed, and there is no use of the prophylactic. Only if the baby needs, then early rescue surfactant therapy can be given. then gentle ventilation strategy should be used, so that we have to ensure that the baby is comfortable in whatever interventions we are giving. We have to avoid the invasive ventilation. And sustained inflation is not practiced. Why? Because this sustained inflation will increase the PIP for 5 seconds or longer, which will increase the risk of damage, mucosal damage. So this is we have to, whenever we are giving oxygen to the baby, we have to ensure we are giving blended blender while giving the oxygen. And this is like the FiO2, we can give FiO2 of 21% by simple room air, and we can give 28 to 35% of FiO2 when the oxygen in liters per minute is 0.5 to 1 and 6 to 5 is the air. So we have to use a blender, and it should be humidified and heated. So it shows that we have to ensure that oxygen saturation, if the baby is having the oxygen saturation of below 60 in 1 minute, then it is of concern. But if the baby is having 60 to 65% of oxygen saturation, SpO2, in 1 minute, it is fine. So this table shows that we have to avoid hyperoxia, because the complications are there when we are giving high oxygen. So for first 5 minutes, so the SpO2 level is maximum is 85%, 80 to 85%. So in the first 5 minutes, we don't want the FiO2 to be such that it is increasing the SpO2 beyond 85%. In first minute, it should be between 60 to 65%, because baby is adjusting with the ex utero life. So it is absolutely fine with the 60 to 65% SpO2. And after that, after 5 minutes, or maybe when the baby is there, baby is resuscitated, and now we are giving the observational care on the post resuscitation care, then we have to ensure that the saturation is between 90 to 95%. It is not crossing that level, because then again it will be causing the oxygen toxicity. Now there are advantages of nasal CPAP, which reduces the upper airway resistance, helps to establish functional residual capacity in the lungs, and then it decreases the chest wall distortion. It augments the spontaneous breathing efforts. So the baby is at ease, because the PEEP is always maintained. Then it preserves the endogenous surfactant, decreases the need for surfactant administration, and decreases the need for and the duration of INV. Now, PPV over sustained inflation. The positive pressure ventilation is always preferred over sustained inflation, because it gives intermittent positive pressure ventilation with the peak and expiratory pressure. In sustained inflation, inflating pressure is held for longer than 5 seconds, which can increase the risk of neonatal deaths, and it should not be practiced. Early surfactant therapies, like this, is administered within 2 hours. If we have to administer it, we have to give it, like if the baby's, the indications are there, like the baby is, the condition of the baby is worsening, even with the FiO2 of 30 and CPAP pressure of at least 6 centimeters of water, then we might need to give surfactant, and it is always better to give early surfactant, because then there will be less need for mechanical ventilation, and it will decrease the risk of air leaks and the bronchopulmonary dysplasia. And there are different MIST and LISA, that is minimal invasive surfactant therapy and least invasive surfactant administration are always preferred over the INSURE, which is intubation, surfactant therapy, and extubation, which is an invasive procedure. So we have to use either of these two methods. And the type of surfactant which is used is the poractant alpha at an initial dose of 200 milligram per kg, then the 100 mg per kg of the poractant alpha or boractant for rescue therapy. Then we have to ensure the optimal humidity and temperature while giving oxygen administration. So we have to ensure that the temperature is 37 degrees Celsius and the humidity, that is 100 degree relative humidity, is maintained, and that will prevent the heat and water loss and preserve the gas exchange, preserve the energy for growth. It will reduce the risk for infection and improve mucociliary transport system, and it is always preferred in non-invasive ventilation. So gentle ventilation means CPAP, giving CPAP, then the non-invasive respiratory supports. Heated and humidified gases are used, and when we are using mechanical ventilation, we have to avoid ventilator induced lung injury. By using volume targeted ventilation, then the pressure or the time targeted ventilation, because the volume trauma is in the neonates is found to be more dangerous. And we have to ensure permissive hypercapnia. We have to avoid hypoxia and hyperoxia, and we have to early extubate the baby. The NRP 2020 guidelines says that for a heart rate assessment during neonatal resuscitation at birth, we have to auscultate instead of palpating the pulse. We have to auscultate. We have to use pulse oximetry for SpO2, and it is always preferred. It is always better to use the 3-lead electrocardiography. Then support to cardiovascular system. We have to support the cardiovascular system, like we have done the respiratory system, supporting the respiratory system. Likewise, if the baby needs chest compression, we have to start the chest compression when the heart rate is below 60 with 100% FiO2. So the chest compression, if we are giving, we have to give with the 100% FiO2 because it is found to be having better results. So if the baby doesn't need chest compression, then we can give FiO2 of 30 in the preterm babies and 21 air in the term babies. And if the baby needs chest compression, then we have to give 100% FiO2. We have to maintain normal perfusion and blood pressure, detect shock in the compensatory phase, and we have to monitor heart rate, capillary refill time, and blood pressure. Capillary refill time we can check by pressing the sternum for 5 seconds and then releasing. And the treatment include early IV access. So we have to give the early IV access through the umbilical venous catheter. And because if we are delaying it, then there is chances of bacterial colonization. If needed, we have to give NS bolus, and if it is not improving the baby's condition, then vasopressors are needed. So hemodynamic instability also is one of the predisposing factor for intraventricular hemorrhage. So we have to ensure and we have to try to make the baby hemodynamically stable. So this also shows that
Dr. Shilpi, you have 2 more minutes to.
Okay, ma'am. Thank you.
Yeah.
So we have to maintain normothermia. So these are the different ways by which we can maintain normothermia by using pre-warmed hat, pre-warmed linens, no drying, avoiding draught of air, plastic bags, new wraps. So these are the wraps which are used for the preterm babies, and heated mattress and overhead warmers. We have to give nutritional care, and we have to give a total parenteral nutrition in day 1 itself to prevent catabolism. And before that, we have to start with the dextrose infusion. And the prevention and treatment of sepsis is very important. So we have to practice strict asepsis in the NICU. So there is another session on this topic. So early antibiotics is indicated if we are expecting the baby has infection, early onset sepsis. Then other care includes skin care, lab investigation. We have to send the sample for CBC culture and chest X-ray, monitor and record vitals, and counsel the family members. It is very important. Then breastfeeding, and we have to ensure mother and child together and KMC. So take home message, the temperature in the delivery room we have to ensure, and the babies who are preterm, they might need polyethylene plastic bag wrap and a thermal mattress. PPV, if it is needed, we have to give with the 21% oxygen. And so these are the 10 steps, 13 steps of golden hour management.
Yeah.
Thank you so much.
Thank you, Dr. Shilpi, for the excellent presentation. Dr. Bharti, your comments?
Thank you, Dr. Shilpi, for that wonderful and a very summarizing presentation of the golden hour. And as you well summarized, it is shown that all healthcare personnel should be timely, agile, aware, cooperate, coordinate, and partner together so as to deliver all these interventions in the first hour. I have one question for you. What do you think is the most important, or do you think is a facilitator for translating all this evidence into practice? If you could say one or two of them.
What is the most important intervention, ma'am?
Or most important facilitator to translate everything? You said there are 10 steps. How can we ensure that these things could be translated to practice?
Okay, it will be translated. So the team leader, role of the team leader is very important, who has to ensure and who has to delegate the responsibility to the team members. And the team members also should be experienced ones, and they should have the experience of managing such newborns. And I feel that all the steps are very important, and all the members should be actively participating in this.
Thank you, Dr. Shilpi. I think that's a wonderful answer from your side. If the audience would have any questions, I think we could take one or two of them.
Yeah, the attending participants could put up the questions in the chat box. So once we finish all the sessions, then we can take them up.
I'm Parul Dutta from the group. So it was an excellent presentation by Dr. Shilpi. So one point, not any questions, one point just for addition. In the first golden hour, one of the most important responsibility of the nursing personnel in the delivery room is also the identification of danger signs and the identification of the baby, which will be shifted with the mother to the postnatal ward and which will be shifted to the special neonatal care unit or NICU. So that will be included, I think. That is one of my opinions. So I like to share these things. I think it will be beneficial for the listeners also, participants also. Thank you very much.
Thank you, ma'am.
Thank you, Parul ma'am, for that comment. So thanks to the speaker, Dr. Shilpi, and the chairperson, Dr. Bharti. We would now move to the next session, which is immediate KMC. I think it's one of the most relevant in the current state of neonatal affairs. The speaker for this session is Ms. Ira Dayal, and the chairperson is Ms. Dr. Poonam Joshi, madam. I would like to ask Dr. Meena ma'am to introduce Ms. Ira Dayal.
So it's my pleasure to introduce Ira Dayal, and she is very young and dynamic nurse leader, and she is very active in NNF activities also. At present, she is working as a nursing tutor at AIIMS Bibinagar, Hyderabad, and she has 3 years of experience, clinical experience at the bedside. So welcome to the session, Ira.
Welcome, Ira. And I would like to welcome Dr. Poonam Joshi. She is the professor cum principal of the College of Nursing at AIIMS Kalyani. And her CV includes a lot of awards and a lot of achievements, publications. So welcome, ma'am, as a
Thank you.
chairperson for this session. Ira, you can share your slides and start your presentation. You have 10 minutes. I will give you a reminder 2 minutes prior to ending your time. Ira, are you able to share your slides? Meena ma'am, can we move to the third session so that we can contact Ira and see what is the problem?
Okay, I just,
Yes.
sure. So then
Will-
next is, yeah, we can start the next one.
Yeah.
So for next session, family integrated care, right?
Yes.
Okay, so we can
Family
start.
Integrated Care by Dr. Gitanjali Kalyan.
Yeah, so let me introduce Dr. Gitanjali Kalyan. She is also a very young and, very young and dynamic nursing leader. And, lots of hopes depends on her because she is the one now who is bearing the torch. And she has many publication like, she has 15 years of experience, and in 15 years of experience, she has 47 publication and she has book 21 book chapter. So, she's working as a nursing faculty at National Institute of Nursing Education, PGI Chandigarh. So, welcome to the session, Gitanjali. And she has also done her master's from AIMS College of Nursing.
Welcome, Dr. Gitanjali. It's a pleasure to have you as one of the speakers. The chairperson for this session is myself. I'm Dr. Kavita. I'm the Associate Professor in Department of Pediatrics, Goa Medical College. Dr. Gitanjali, you can start your session.
Good evening.
Can you make it
My
slideshow?
slides are audible. My slides are visible. Am I audible?
Yes, but the slides are okay. This is good. Thank you.
Yeah, okay. First of all, I would like to thank the organizers for giving me this opportunity. We are going to talk on a very important topic that is family integrated care, or we can say family centered care, though there is a little difference between the two. And I would like to say that this is one of the topic very apt being chosen on for me to speak on this particular day, which is related to the mothers and to the nurses, because both nurses and mothers, they play very important role in empowering. Mothers empower their infants, their children, and the nurses, they empower their uh, the families, or to the also to the patients. So in nutshell, we can say that major component of family integrated care is empowering. So we want to empower first the nurses, that how to integrate families in the care of neonatal system, and then the nurses will empower the families. So this is we are going to talk about the outline of my presentation is introduction and need of FCC and FIC. We will talk about a little difference. What is the difference between FCC versus FIC? Though the terms are being used synonymously by majority of the authors. Components of FIC and day-to-day information, which we all need to incorporate in our day-to-day practice. Then benefits of FIC, and I will also touch upon a brief overview of family integrated content of our unit and how it benefited our families and the neonates. So, advancement in neonatal care is associated with improvement in survival of preterm neonates. The neonates born too soon spend a longer time in neonatal intensive care. This new experience creates a feeling of powerlessness among parents. I request to please mute yourself. It's creating a little trouble. Thank you. Okay. So this new experience create a feeling of powerlessness and helplessness among parents. Why? Because every new parents want to take their baby home. They want to celebrate the birth of their baby. However, the baby is now inside the NICU and the baby require a longer duration in neonatal care units for their survival. So it has been described by various authors that the environment of NICU is traumatizing for both babies and for the parents. For the babies, because they have to undergo numerous painful procedures. There is sleep interruption, constant noise, unwelcome handling sometimes, discomfort from feeding, medication, devices, and sometimes they have to deal with respiratory failure. They have to go on ventilator like that. And for the parents, they have lack of control over the events. They just observe as bystanders, and some in the unit, especially where they are not involved in the care, there is a conflict sometime with the staff, because staff, they feel that they are superior and whatever they are doing is the best. And sometimes there is a conflict between these nursing officers, physicians with the parents. There is a guilt among the parents that they are not able to do anything for their baby. The baby is inside the ICU and they are not contributing to the baby's well-being. Sometimes it's a difficult place to recover from the delivery for the mothers, especially if the mother has delivered a baby through C-section. Mother is supposed to see the baby. She has to come from from her bedside to the newborn unit. So sometimes this creates a difficult situation for the parents if the parents are not welcomed properly, they are not being offered a place, and we do not understand their feeling or emotion of being unwell or something like that. So it creates a stress among them. And there are a number of rules definitely in ICU. There are inconsistencies in communication. We all need to learn about communication and how to deal with the parents and the principles of interpersonal relationship. So these all things generate a huge amount of stress, anxiety, fear, dissatisfaction, loss, grief. And solution to it is family-centered care or family-integrated care. So family-centered care, according to American Academy of Pediatrics, they renamed it patient and family-centered care. According to American Academy of Pediatrics, it is an innovative approach to the planning, delivery, evaluation of healthcare that is grounded in mutually beneficial partnership among patient, families, and providers that recognizes the importance of family in the patient's life. So family-centered care is aimed to maintain and strengthen family roles, the natural bond the family has with the infant. To extend the responsibilities of pediatrician, it includes screening, assessment, and referral of parents for physical, emotional, social problems or health risk behaviors that can adversely affect the health and emotional or social well-being of their child. So if the parent is not well, they themselves in the stress, they are anxious, they won't be able to contribute effectively in the care of the baby. And this stress in return reduces the output of the breast milk also. So we need to understand every family is dealing with the unique challenges. They are dealing with so much. So we need to understand it. We need to talk to them. We need to find out what problem they are facing. And then we need to refer them and to promote a healthy family functioning. So these all are the aims. The core components of family-centered care include dignity and respect. Listen to the parents, honor them, listen to their perspective, their choices, be with them, and be a supportive person to them. Then coming on to the information sharing, information should be shared as unbiased. It should be unbiased, and we should give them complete information. Although we also need to see the state of mind of the parent. How are they? Is there any support person with them before we reveal information? Like, we will learn about this more in the end of life care also, and should be timely and accurate. If we are giving any information nearly at the uh, end of care, we have not revealed the truth to the parents, it may come back to us badly. And then participation in decision-making process and collaboration between families, patients, and healthcare providers. So these were the core components of family-centered care. So now family integrated care came, this is a new word come up. So we need to understand there is a little difference between the two. FCC majorly involved those 4 components which we just talked about, like that involves allowing the parents to come inside the ICU and participate in decision making. It does not involve active participation of parents as practitioner or 2 partners in the care. So this is the basic difference between the two. So FIC is an actionable model that was introduced by Shuli at Mount Sinai Hospital. In this, the parents or the family participates as true partners or practitioners in the care of their infant inside the NICU. So this involves more amount of involvement by the healthcare providers to empower the families so that they can participate in actual to provide the care to the baby. So family integrated care goes well beyond merely allowing to enter and participate in decision making. So we need to allow parents to practice the care actually. So these are the components of family integrated care. So first component of family integrated care is respect and dignity. So we need to address the parents with respect, dignity when they are coming to the unit, or if they are coming to get any information to us. Then coming on information and counseling. This should be, there's a word written provider initiated. In our health setup, in Indian health setup, especially the parents, they have a fear of talking to the doctors or sometimes to the nurses. They are more comfortable talking to the nurses and they are more hesitant talking to the doctors. They are uneducated sometimes, or they feel that doctors are the big personalities and it's difficult to talk to them. And moreover, sometimes they are always busy, so they feel hesitant to talk to them. So we need to fix up some time of the day where the both nurse and the doctor are available to the parents, and they give them information, and they also counsel the parents. Then coming on to the assessment of problems and needs and referring them accordingly. We have discussed this in FCC. This is also a component of FCC. We have already discussed in previous slides. Then fourth point, which is the most important point, is empowering the parents. We need to educate them. We need to have content in the local language which parents can understand. We need to provide them information in written, in pictorial, in videos that help them to go through it, and it becomes easy for them to understand it. And we need to involve them care. First, initially under the supervision, and later maybe they can practice independently also some of the skills. Then informed decision making. We need to give them complete information and then help them take an appropriate decision for the outcome of their neonate. Then collaborate with team and family. We may have to collaborate with number of individuals. We may have to collaborate with the with the physiotherapists. We need to collaborate with the technicians. We may collaborate with the nurses. We collaborate with the other members of team, like sometimes to the radiologist, or maybe sometime to the surgeon. So we need to collaborate among the team and with the family. We need to provide them appropriate information. See, your baby's is having this problem and we have to shift to the baby to surgical unit, or we may have to get the radiological investigation done. So the portable machine will come, or either if they have to take the baby sometimes. So we need to give them appropriate information. We need to collaborate first among ourselves and then with the family. And then we need to promote parent-infant interactions. To do that, we need to have a liberal visiting policy. We need to understand that the parents are the ultimate care providers of the neonate, of the infant, and they need to come and interact with the baby. Only then they will have a bonding, they will have attachment, they will be able to participate in the care. So we have to have a liberal visiting policy for the parents. And then comes the last component, that is parent to parent support. So we need to develop a system inside our hospital that is also a provider initiated parent to parent support. We may create groups for the parents, and we can display the QR code for the group. Like if you have created a WhatsApp group, display the QR code, all the parents can join, they can interact with each other, they can share their problems over there, and they can support each other also. Then we facilitate parent to parent interaction in the mother's room. We may invite some of the older mothers to interact with the newer mothers. They can share their experiences with them. So this is how the new parents, they get support of the older parents, and that help to build a confidence among them that yes, their baby can also recover. So this is the slide depicting day-to-day information, that these are the components of the day-to-day information. We need to fix up a time of the day to offer provider initiated information and counseling, where we need to follow the rules, we can say, or we can say the principles of day-to-day information. So first is introduce yourself with the name and designation. Inform about the activity of the baby, when the baby woke up, when the baby took rest, how many times the baby passed urine and stool. The parents verbalize this thing, that we need to know about our baby, what the baby did throughout the day. Then inform about daily weight of the baby, vital sign of the baby. So sometime mothers say हमें बताते नहीं है कब मशीन बीप कर रही है, ये मशीन इतनी तेज बीप क्यों कर रही है, हम डर जाते हैं. So we need to explain to them that what happened to the baby and how we managed it, and they need not to worry. We are there to deal with the alarms and we will take care of the baby. So what investigations have been sent, and what is the report, what is the outcome of the investigation, what is the expected time for a baby to stay inside the ICU. Although we cannot predict, but yes, there is some expected time that we have for each baby. Like a baby who is born 28 weeks, a baby who is born 32 weeks, or a baby who is born 34 weeks, there is a difference in their stay. Although the stay also depends upon the condition of the baby, but yes, to some extent we can tell them the expected time. So outcome of the treatment, we need to tell them what is the outcome of the treatment we have given to the baby. Like when your baby was put on CPAP, we give the surfactant, how the baby's lung responded to it. Likewise, we need to explain them. Then machines used to nurse and provide respiratory support to the baby. Sometimes parents are worried, so many machines are attached to the baby, what is their role, what these machines are going to do. So we need to like they have a fear, like babies under radiant warmer, or sometimes they are inside the incubator, what is this machine. So they need to understand that these machines are for providing warmth, and how these are going to help in the outcome of their baby. And then finally we need to tell them about the prognosis of their baby. So recently in 2022, in one of the Journal of American Academy of Pediatrics, a Cochrane review was conducted by Kristen North, and it was published in this journal. And they specifically conducted this study on all the RCTs where the family integrated care was introduced. And they reported that it helped in decreasing retinopathy of prematurity. It decreases the length of stay in the hospital. It significantly reduces the parental stress and anxiety. And then it increases the weight gain velocity, and it increases the predominantly on exclusive breast milk intake. Improves if the mother is engaged in the care of the baby. They also reported that it can decrease bronchopulmonary dysplasia, infection, interventricular hemorrhage. They also reported that there are no benefits on mortality and necrotizing enterocolitis, and certainly this is evidence which is of low to moderate this thing. So considering these benefits and also from the earlier papers and earlier Cochrane reviews, we plan to develop an orientation cum training package for integrating families in our ICU. These are the components of the booklet, some for the written material, which was developed in local languages and also in English, and the booklets are available for the parents to use. And these are the different pamphlets we developed, like what is family integrated care. We also developed a pamphlet on orientation to NICU, a complete booklet about orientation to NICU. What machines the babies are kept in, how long the machines can stay. Likewise, information about premature baby, what to expect from a newly born premature, and then gradually, and then hand washing posters, kangaroo mother care, breastfeeding, retinopathy of prematurity, poster on method to feed with the spoon and katori. And likewise, these are the components of the booklet also. So this is a glimpse of our videos, video on orientation to NICU, video on how to massage the baby, video on how to provide skin care, video on why it is important to wash the hands. And this is the glimpse of our pamphlets like Suman Ke for the hand washing, like नवजात इकाई और देखभाल प्रणाली के बारे में जानकारी, that is what is NICU and how the care is being provided. We also develop an app that is NICU FIC app. You can download the app in your phone, and parents can also download. They can log in and they can see the content. This is the logo we prepared on family integrated care, and then once you sign up, you remain logged in for rest of the time. And this is how you get the access. And there is information about updating the information about the babies, how to see the videos. There are pamphlets in the more information, and there are FAQs component, and these are videos developed in Hindi, English, and Punjabi. This is the review of the videos in Hindi. So in our ICU, mothers is
Dr.
welcome.
Gitanjali, 2 more minutes. Can we wrap up?
Yeah, I'm going to wind up in 2 minutes. Mother is welcome 24/7. Mother is given orientation and involved in care after giving demonstrations. Fathers are allowed to clarify the doubts anytime, and also they can participate in the care in 5 to 7. Although we tried hard to allow fathers anytime, but sometimes our nurses were hesitant to it, because especially for the summer seasons where the fathers are coming from the work, they are drenched in the sweat, and nurses strongly feel that if unless we have a bathing area for the parents, it's difficult to allow them drenched in the sweat to come and provide care to the baby. So they encouraged between 5 to 7 p.m. provided the parents are clean and they have taken bath or something like that. The fathers have taken bath. We utilized valid and tested content. We observed family integration improved from some to moderate level in our unit. A significant decrease in mother stress level and an improvement in satisfaction level was observed with implementation of this model. The exclusive breast milk feeding and feeding day and duration of KMC improved significantly with the implementation of this model. The implementation of model did not demonstrate significant improvement in weight gain or loss, because this may be because we discharge babies little early. The sooner they get stabilized, we shift them to the nearby SNCU, the readmission rates also in the survival. No increase or decrease was observed in HAI and length of stay. So take home message is family involvement has a beneficial role on several infant and parental outcomes. All healthcare providers must strive to adopt this humane care in their neonatal care units. Thank you so much for giving me this opportunity, and I also thank all the entire NICU team, Tiny Tots, and their families who have contributed significantly in development of this package. Thank you so much.
Thank you, Dr. Gitanjali. What a splendid presentation. I think you emphasized the importance of family integrated care so well, and what amazing work you have done in developing all the parent information and videos, etc. One question I had. what do you think is the most important barrier in doing family integrated care? Now you have tried to do family integrated care and you've also been successful, but when during your implementation of FIC, what you thought was the biggest barrier of FIC?
The biggest barrier I realized was information and counseling. Like we in our hospital, we have the residents, the nurses from all over the part of the country. Sometimes they were many of the physicians especially said they are not trained in information and counseling, and they do not have too much of time to spare with the parents, and sometimes they are short of words that they can use to give the information and counseling to the parents. But they also accepted that the written content, the videos are really helpful for them to integrate the families, and this has helped to break the barrier. So this is how we felt that this is one of the barrier. And another barrier was sometimes the nurses was little bit hesitant in paying so much of time on sometimes like helping parents to download the app, to utilize the videos. They were initially hesitant. So these were the barriers, but later on we'll overcome them.
Right, I agree. So the only way is to make all the healthcare providers understand what is the long-term effect of the stress that the patients and the parents undergo in our NICU, and this is going to actually improve the outcomes.
We also need to make them understand that the parents are low-cost resource, which is always available, and this in return, if they will utilize the resource, in return will decrease their workload rather than increasing their workload. If we empower the parents, definitely they will contribute significantly in doing many minor procedures, which the nurses spend too much of time on. So in nutshell, it is beneficial for them also.
Thanks, Dr. Gitanjali. So we move on to Ira. Ira, when you were offline, we have already introduced you, so you can please start your presentation straight away. Dr. Poonam is your chairperson. You can share your slides.
Am I audible?
You're audible, but we can't see your slides.
Okay.
I think she is having some network issues.
Without slide, you can start.
Maybe, Ira, you can share your slides with me. You can email them to me. I'll share on your behalf, or maybe to Dr. Kavita or to Meena ma'am, anyone.
I'm not sure whether she can hear us. I think her network has gone.
Shall I call her? I'm going to call
Just
her.
to
Maybe
save
we can
time, we
proceed with
can
the
move
next
to the next
presentation.
session. Otherwise, we are getting late. We can
Yeah,
move
yeah.
to the next session till the time
She's come
making
online.
her.
Yeah.
She has come.
Ira, can you now continue? Share
Yes,
your slides.
Lot of network issues I'm having. Now
Put it on slideshow. Yeah, we can see your slides. Put it on. Yeah, good. You can go ahead.
So, a very warm good evening to everyone. Thank you, Poonam ma'am, for introducing me. I have some network issues here. And very happy Nurses Day to everyone and Mother's Day to all the mothers. So the topic that I was given, I want to thank NNF for giving me this topic and this opportunity. The topic is IKMC or immediate KMC, and I think many of us are still not very aware of what IKMC is. And when I think of IKMC, I was just remembering the onset of or the introduction of airplanes into our lives, right? Today, we can't think of going anywhere without actually booking a flight. But many, many years ago, people didn't even think that they could have actually flown. And at that time, it seemed like something impossible. And probably that is around the phase that we are right now with IKMC. When we think about it, we read about it, we literally think like, is that possible? Is it actually possible? Even though it's very useful, very beneficial, it has been proved. But then is it actually feasible? Is it possible? But today we can't, think of going anywhere, like I said, without flight. So that is how IKMC, we all should believe and strive forward to make it happen. So I just actually wanted to quickly recap on KMC. I know I have only 10 minutes. Maybe I'll just take 2 minutes to recap. So when we look at KMC, and this is just so that it's an important topic. It's a very common one, but just to recap. So kangaroo position, as you can see in the photo, it's the baby directly on the mother's chest, skin to skin, with the hands near the face, legs flexed, and the head tilted in a way so that the mother can see the eyes. this position, this should be given at least first session, or the session should be at least 1 to 2 hours, not less than that, so that we're not disturbing the baby. And it should be given for all low birth weight babies, stable ones. Note that. And also it should be given till the baby is actually wiggling out of that position on its own. Kangaroo nutrition is exclusive or near exclusive breastfeeding, and kangaroo discharge is early discharge and regular follow-up. Criteria is all stable low birth weight babies, as we know of KMC, and babies on ET, on any oxygen supplements, willing mother and relative who is in good health and hygiene. And one thing that I just wanted to focus on for all the nurses who are especially working in NICU who are listening is to enable movement. Often when we work in NICUs, we just think that, okay, the mother is in KMC and the baby is in KMC, both are together, both are resting, and we are very happy, we are relaxed, we are satisfied. But I think that's something that we should move out of now. All of us NICU nurses should actually start thinking of having the mothers walk around a little bit in the NICU. If you're doing it in your NICU, that's great. But otherwise, if not, then you should start encouraging the mothers to get up and move about, see the stability of the bed, of the tie that they have, the wrap that they have. Is it actually holding the babies? Are they confident to move around? That would actually ensure that the mothers continue KMC when they go back home, because that is also important. So I really want to encourage all the nurses listening who are working in NICUs or are related to NICU in any way to start implementing this in their care. And then I wanted also to just show this, like not just, and like the previous photo, the blue one, that is the ladle wrap, but otherwise any, even saris, dupattas, and even the pagdis which are there, those can also be used to include men. And I wanted to just know, what about the surgical cases in the NICUs that everybody is working in? Because as with my experience, what I've seen is that many times the patients are very scared, not the patients, sorry, the mothers, the fathers, they're very scared to touch babies with any kind of surgical conditions. And we had one nurse come in from America. She was a nurse practitioner in the NICU, and she said that they are giving KMC to babies on side lateral position, or like this reverse position. This is from a different study on evaluation of ROP screening, but these positions can also be used for surgical cases. So she was saying it gets really messy, but they actually give KMC to surgical cases. But just to break the barrier of that fear which is there in the parents' mind, that is something that we all should work in. So I don't know how many of you are able to give it to surgical cases, but this is also something important. Benefits of KMC are many, so we already know it. I won't really touch upon it, but if you just want to have a quick read, we already know them, and these are them. So now, what is immediate KMC? So as per definition, immediate KMC is KMC which is to be started soon after birth. So initially I was thinking that it is happening immediately after birth, which is like we call skin to skin. But then when I talked to Dr. Suman Rao, she said that in the study that happened, it was actually within 2 hours. So soon after birth, within 2 hours, and to be given continuously, aiming up to 20 hours per day before and after stabilization. So here we should know the difference between IKMC and KMC. IKMC is actually, the golden point is that we are actually trying to give KMC before stabilization. So let's look at the next slide to understand. So why do we need IKMC, and where was the lactation? So we know that the KMC that's going on now is that the baby is born. We take some time to stabilize. As you know, if you work there, you know that if the baby is having a little bit of retractions or excessive secretions, or anyway where we're not very confident, okay, that the baby is like ready to go to skin, we'll take the baby to the warmer, stabilize the baby, and sometimes the baby has to be shifted to the NICU to get a little bit of CPAP or HFNC. And then when the baby, we feel like, okay, now the baby is stabilized, then we ask the mother to come in and start KMC, and that usually takes maybe a few hours to even sometimes days. But what was seen is that majority of deaths are actually happening before stabilization. So what the IKMC, the thought process behind it was, like, can we start KMC before stabilization? Is it feasible? Is it actually doable? Is it safe? Is it efficient? So for this, a multicentric randomized control trial was done by WHO. In this, I'm not going to go into the details of the study, not at all, because I know that as nurses, we don't need a lot of theory. We just need to understand what things are and what are the practical points. So here, I'm just going to basically explain what happened mainly in the control group. There were a lot of babies, but one important thing to know is that they had a lot of babies and like screen or eligibility criteria was checked. But finally, in the experimental group, there were only 1,602. And in the control group, I think 1,609. In this, neonates with weight of 1 to 1.799 kgs were taken, and mothers with identified surrogates. So what they did is, before delivery or sometimes after delivery, if the mother was not enrolled before, she was asked to identify surrogates who could give KMC when she is not available. This happened in Ghana, India, Malawi, Tanzania, and Nigeria, 5 countries, tertiary level hospitals. And which kind of babies were excluded? This is also important to know. So babies who were not able to breathe on their own within 2 hours, or who had some major congenital anomalies, they were excluded from the study. So what happened? Now this was the experimental group. The control group got the normal regular care. There were significant changes for this IKMC to happen. So the first thing that happened was a MNICU, or the mother NICU, which was a modified in some of the centers, and in some centers they had a completely new NICU. We'll discuss this further. This was an NICU in which the mother was staying next to the baby's warmer. So now I wonder how many of our centers are actually having this. Right now I'm in AIIMS Vivnagar. We have only a 6-bedded in NICU, but we are trying to, or the doctor there, the neonatologist there, they are trying to implement the mother NICU, where the mother's bed is next to the baby's warmer. All care was provided on KMC, or very minimal gaps were given to stop KMC. And any interruption in KMC was documented in this study. And another new thing is that essential postpartum care was provided by the OBG doctors in the MNICU itself. Otherwise, what we see in regular things, or in my experience, what I've seen is that the mother is in the postnatal area, and that's where the OBG doctors see them. Or if there's any significant, sometimes they even have to stop KMC and they have to go and meet the doctors. So what was the result of this study? There were many things that they have seen, but the most significant thing that they saw was that neonates who received IKMC were 25% more likely to be alive at 28 days of life. So at 72 hours of life, there wasn't a significant difference, but at 1 month or 28 days, 25% chance of being alive was there. There were also other impacts, like there was less suspected sepsis, less actual sepsis, lesser episodes of hypothermia. And we could say with this intervention, according to one report, we can save about up to 150,000 babies per year. So what exactly is IKMC? So IKMC, the components for us nurses to simply understand is KMC started immediately after birth. So we can have, so here immediately after birth is initially what I was thinking, but in the study, what they have done is like at least within 2 hours, they should be able to start the KMC. So on the mother after delivery is what we sometimes see, also we have practice in our NICUs. Then on the mother when labor room care is being given, that can be done. First breastfeed on the labor table. Okay, this is not part of that, but this is included. If we're doing IKMC, this can also be done. And KMC should be started within 2 hours of birth. Then transfer to NICU. So in some of the centers, the babies were being transferred to the NICU on the mother. Like you can see here, this is actually from, I think this is Safdarjung, if I'm not wrong. This is from one of the videos that WHO released. And babies, you can see the babies wrapped onto the mother and babies on the wheelchair. Then the mother and ICU, this was one of the biggest change. This was also one of the biggest hurdles or the barriers to IKMC. As you can see, because this involves a significant change in the infrastructure of the NICU, where the mother's bed or the chair is near the warmer. There is minimal separation, where the mother is continuously giving care to the baby. If not on KMC, she is changing the diaper, she is feeding the baby. All care is given on KMC, or maximum care is given on KMC. And another important thing here is that pantry, washroom facilities, they ideally should be there in the MNICU, so that the mother is at comfort. Otherwise, it's difficult. Then OBG care in MNICU, where the basic rounds, the basic care for the baby happens in the NICU. And like you can see here in this photo, this baby is on CPAP, this baby is on KMC. So I put this photo here because I just want to put a practical point. Like sometimes when the baby is on KMC, you can see how the nose is really smudged or pressurized with the CPAP. So this is something that we nurses should see when we are implementing KMC in our units. I just wanted to put a random point in here that even though we are doing these things, these are some important things that we as nurses should know. So OBG care in MNICU, basic rounds, which are not there in a typical NICU, these are also supposed to happen or were done in the study in the MNICU. Now, I hope you got a basic understanding of what IKMC is. So we'll just discuss what are the barriers of IKMC. I just want you all to just imagine like you're an ICU being turned into an IKMC. There was definitely a large, large benefit that we saw of this study, where babies have 25% more chance of being alive. So let's just look quickly at what are the barriers that can be there to IKMC. And I also had a talk with Dr. Suman Rao ma'am and Dr. Pratima Anand ma'am regarding this. So I think one of the barriers, now I have not actually practically done IKMC, but when I was there, we had a few discussions, and then also it seemed to be something difficult. So the infrastructure of the NICU, most of the NICUs that we have, the traditional ones, are typically built for the babies, and some very it will be difficult to probably it may be easy to put in a mother's bed, but then the other things of the NICU where you're making it easy for the mother to live, like having simple facilities of toilets, of pantries, of areas where they can sit and eat, where it is easier for the mother to actually be closer to the baby. Then a physical route between the labor room and NICU. If in many NICUs, they still do not have an easy route between the labor room and the baby is born to the NICU, which is safe. In some of the cold temperatures, if we're actually going out of the labor room and we're into an open exposed area, and then we're going into the NICU, so we are really exposing the baby to hypothermia if the babies, even if the babies are in skin to skin. Like in our labor room, what we used to see is that we had AC, centralized AC, and we used to give skin to skin, but then still in winters we needed an extra blanket on the baby. So imagine in this condition, if the baby is being exposed to the outer environment, then again it's difficult. Knowledge, attitude, and compliance of first level warriors. So I want to call the nurses who are in front line and the doctors, the SRs, JRs, who are working day and night as the first level warriors. When we're fighting against mortality, I want to call them the first level warriors. So their knowledge, their attitude, and their compliance is most important, because during the day shift, during the 9 to 5, it's very easy for people to be compliant and everything. But as the evening comes in, and when the night shift comes in and everybody's tired and there's the typical less staffing, then it becomes difficult. So their knowledge towards it, their attitude, their compliance, and the senior level administrators, they also have a very strong role in this. Then, according to Dr. Suman, ma'am said that they're finding a surrogate, a replacement for the mother when she's not able to give the IKMC. Finding a surrogate was sometimes difficult. And the study itself reported that many of the NICUs are actually not allowing mothers and their relatives to come in. So that itself was a major change when the study was done. Then, yeah, like I've already mentioned, the next point. And another thing that we should consider before we think of IKMC is that actual KMC and skin to skin at birth itself being done well. So ideally now what we should do is, as soon as the baby is born, and if the baby is stable, the baby should be kept on the mother's abdomen, all the care, whatever is needed. Now suction has also become like if needed only. So baby should be dried, baby should be wiped, kept on the mother's, checked there. I would even encourage vitamin K to be given there, and the weight should be delayed. But is that actually happening? Many cases, when there are supervisors, when there are people who are standing there and watching you, it does happen. But what happens at times when we are short staffed? These are things not talked about, but these are things that we also need to look into, because I think in an ICU, when we're trying to give good care, we actually have to look at the human resources that we have, because they are very important. No matter how many SOPs we develop, how many rules we make, it's very important for us to remember the people who are actually giving the care are also humans. So how many times is it actually possible? The one issue that we faced in our NICU was that the labor room, or in the labor room, was that during night shift there was no staff in the labor room. So then the care that we saw was significantly dropped during night shift, simply because there was no labor room nurse. So the nurses had to come from outside to inside when there was a delivery. So that itself becomes very difficult for a person to manage both out and in. So if she's
Meera,
managing
you
the
have
mother.
a minute or so. Can we wrap up in a minute?
Okay, yes, ma'am, I'm almost done. So these itself are things that we need to think about. Another thing is nurses in NICU taking care of both the mother and the baby. So we know that NICU nurses, they are very, very, strong towards the baby. And often you can see that they are more for the baby than for the mother, some very dedicated nurses. So them having to have a major mental shift of now also taking care of the mother. Some obviously do listen and talk to them, but when it actually comes to monitoring them and looking at them when they're in the bed, that is a major mental shift that we need to start implementing or start thinking about as nurses when we want to think of the future as being IKMC very positive in the country. Night shift, like I already told, the practical difficulties. SOPs as to when to call the OBG doctors, they should be strong. When is the basic line, when you should call, when you should not call, how much we can manage. And then CPAP and KMC, like I already discussed. What were the facilitators to IKMC? Sorry, that's IKMC. Family inside the NICU, they become very good monitors. We already know as NICU nurses, when the mothers are there, they're much more observant than us sometimes. And even the smallest things they keep telling us, which helps us to monitor the babies better. Good collaboration between OBG and NICU team. This is something that really needs to be developed if we want to think about IKMC as the future of neonatal care. We need to have a very good collaboration between the OBG and NICU team. And thinking about that is, I think it is every site specific, which hospital you're working in, what's the team there. We really need to think about that. And also the MNICU, like I said, it should be well structured for the mother's comfort, because if they are not comfortable, then it does not matter to them. They definitely will try, but they also need their physical comfort. So yeah, like again, this point I think is very important. Like mothers, yes, they are mothers. It's a privilege for them to become mothers. They feel empowered, they feel satisfied and lesser stressed with IKMC. But then what are some of the negative impacts? If you have a KMC center where only females are giving the KMC, sometimes if they don't have a surrogate, many times mothers, they have, told us that it's very difficult for them. And I remember one case where the mother had twins. One twin was in the NICU, the other was outside, and the father came and he asked the mother who was giving KMC to change the baby's diaper who was outside. And at that point, we can't scold the father, obviously, because it will have a negative impact on the mother. And we were just surprised, and we just were, counseling the mother and encouraging her. And she was telling she has to feed the baby outside, she has to pump for the baby inside, she's still recovering post CS. I mean, these are things that we as nurses, we look and we see the patients every day. And these are not things that I was discussing with ma'am, are not actually brought out in research. But we nurses are the ones who should stand for the patients. We are the advocates, and we should see that what can we do so that nurses, so that the patients are more comfortable giving KMC and the future IKMC in the NICU. So making IKMC possible, knowledge and skill building of the entire team, resilience at night. We need to stop this. Okay, I can't say stop, but we really need to think that, short staffing at night. Typically nurses are less during night shift. Is it actually good for NICUs? Is it good for postnatal wards? Is it good for labor rooms? Maybe in general medical surgical wards, maybe okay, but is it good for intensive areas? Flexible building plans, futuristic thinking before the building, easy travel between two areas, train staff. So we can have many practical sessions of IKMC, of the transfer between the sessions, and we can have knowledge sessions about how to take care of postnatal mothers for the nurses, adequate staffing, like I've already talked about. And also we need to look at the generalizability of the study that happened. Like this, is it safe to practice on the same birth weight? Why were the babies who were taken out of the study? We need to again just look deeply into the study and see whether it's actually practical. And way forward, when I talked to Dr. Suman, ma'am said that there are some national task force teams which are working in Haryana and UP who are actually looking at the implementation of IKMC. So maybe in a few years, we may see more IKMC centers and more ways of how to make this more feasible. So related to this theme, we know that we nurses
I'm sorry, because we have 2 more talks and then a panel.
Right,
So,
okay, so I'll just stop here. I've already discussed many of these things.
Yes.
And we as nurses need to know that we are very important when it comes to this IKMC. And yes, that's it. Thank you, everyone.
Thank you, Ms. Ira. Thank you, Ms. Ira, for bringing such a comprehensive overview of IKMC. I know we have come a long way. We just started 50 years back, the concept of KMC, and we are thankful to the person who has introduced KMC to all of us, especially in a resource constrained country. It has its own benefits. So we moved from giving intermediate, I should say, continuous KMC to intermediate, and then finally to immediate KMC. So these are the stages we are going through, and I'm sure in coming days, we are going to include in more and more centers these services, and IKMC and family-centered care is going to be the integral part of every NICU. So we have understood from your talk that it is something doable. The only thing is we have to include mothers, their families in the nursing care, as well as we have to have OBG team to be part of our NICU team, so that we can work in a collaborative manner and make IKMC possible in every ICU. So with this, I would like to thank Ms. Ira for giving us a comprehensive overview. Over to Dr. Kavita.
Thank you, Dr. Poonam. Thanks, Ira. We'll move on to the next session, which is a very interesting topic. It is palliative care in neonates. Ms. Meena, can you introduce the speaker? Ms.
Yeah, so it's the next speaker is Cecilia. She's Associate Professor, College of Nursing, AIIMS, and she has 3 years clinical experience and 17 years teaching experience, and she has more than 20 publications. And my humble request is please stick to the time, and over to you, Kavita.
The chairperson is Dr. Anu Thukral, and Dr. Anu is the Associate Professor in the Division of Neonatology, All India Institute of Medical Sciences, New Delhi. And she is one of the biggest names in nursing training. I've worked with her on many platforms to train nurses online as well as offline. Welcome, Dr. Anu, to this session. And Cecilia, you can start. Yeah, you have 10 minutes, so please stick to time.
Thank you. Am I audible?
Yes,
Yes.
Yeah, I thank the organizers for the opportunity. A very good evening to all of you. We have seen all interesting sessions on family integrated care and also IKMC. Now we'll see what is palliative care in newborn. Actually, the contents that I would like to cover in this would be the significance of palliative care in newborn, a little bit of background, and also what is palliative care of newborn and the various components, who are the children who need palliative care, and about little bit about do not resuscitate orders, and also the phases and components of palliative care. Actually, is when we talk about the significance, a newborn, a birth of a baby is an expectation and a joy for the entire family. Everyone is expecting for the baby, and that is an expectation for nearly 37, 38 weeks to 40 weeks. And so when the parent receives the information that they about their child, the parental bereavement is intense. It is also complicated and long lasting, and at times it can be complicated too. Okay, the psychological consequences may also be bad. And when we talk about the social systems, traditionally we had the joint family system, and when a family faced adversity, it was the family and friends who were supporting these couples. But now with the joint family system fast breaking, and we are moving towards nuclear families, this support is not being met, and that healthcare professionals become a part of it in rendering the support for these families. So it is a responsibility or need to identify and prevent such eventualities, besides adhering to the medical ethics to offer dignity and also for the families. And also it is essential that we should provide necessary information to the family, like for example the cause of the baby's condition, its circumstances, and if at all the baby needs autopsy or any other pending investigations that are to be discussed and also explained, including the implications for the future pregnancies. So all the informations that we provide on these fronts will help the couple to deal with their emotions, and also to come out of their guilt feelings, and also help them to cope with their grief. Okay, when we see the background as such, nearly 25 million children are born in India each year. This is the estimate given by UNICEF. And in 2018, an estimated 0.6 million newborns died in India due to preterm birth and other complications. So the relevance of neonatal palliative care is much more in developing countries rather than developed countries. Not only in the end of life situations, the severely compromised babies are also likely to need very prolonged palliation for the misery in the way that they are suffering. So palliative care as such, it focuses on the holistic prevention and relief of suffering, including treatment of both physical symptoms as well as psychosocial and spiritual concern. It is an active and total approach to the care from the point of diagnosis or recognition, and also throughout the child's entire life duration, and also death and beyond that, support for the family. The components of palliative care, when we talk about it, includes the ultimate goal is to enhance or promote the quality of life of the baby, and also to provide support for the family. It is provided through various aspects like physical support in case of if the parents want to cuddle the baby, their physical presence, allowing them to be with the child, all that. Emotionally, for the parents to be with the child, and also to give information regarding to the condition of the baby. Spiritually, any help can be that is expected from the family, guidance can be given, and social support is also a vital component that is needed by the family during this situation. So who are the children who need palliative care? These can be any child with genetic or chromosomal abnormalities like chromosomal aneuploidies, and also mitochondrial disorders, severe metabolic storage diseases, and also life-limiting prognosis condition, severe forms of skeletal dysplasia, then organ system problems like neural tube defects, migrational disorders, hypoxic ischemic encephalopathy, epidermolysis bullosa, myotonic dystrophies, and all these conditions, and also severe pulmonary hypoplasia, congenital central hypoventilation syndrome. All these conditions may also require, and also other conditions, infection and immune disorder conditions like perinatal human HIV/AIDS, and also severe combined immune deficiency, severe perinatal herpes simplex, cytomegalovirus, toxoplasmosis or Zika virus, all this. Then complications of prematurity as such, when we see the periviable gestation, like severe in IVH, intraventricular hemorrhage, periventricular leukomalacia, then ventilator dependent BPD, bronchopulmonary dysplasia, severe necrotizing enterocolitis. All these conditions also in these babies, palliative care may be needed. And when we come to do not resuscitate, as such, the protocol is all patients in cardiac arrest should be resuscitated unless there is a valid DNR order. But as per American Academy of Pediatric guidelines, DNR orders to be executed with certain criteria, like when the baby is gestational age is less than 24 weeks, birth weight less than 400 grams, anencephaly or major chromosomal abnormalities, and in certain situations when the prognosis is uncertain or there is a borderline chance of survival of the baby, the parental decision to discontinue support system is required, and this has to be documented. So the ethical principles that are guiding all these are like autonomy. Here we have to ensure informed parents' consent for the right to participate in the medical decision making, and also all clinicians and nurses should act in best interest of their patients. Instruction for all the healthcare professionals to do no harm for the patient, and all children and the families should be treated equally, well and fairly, and health resources also should be utilized equitably. And here it is the parents' right whether to accept or reject the recommendations made by the clinicians, and this has to be accepted. Phases of palliative care, in the sense, like from the time that the child is recognized or that's after the death. So pre-death, there are factors like what has to be done. We have to talk with the family in understanding their empathy, their sensitivity, and also help the family in a way that what has to be done. Preparing the family for the sequence is very essential, and also during the active phase of dying, what are the care that are needed for the baby, and also support to the family, and also after death rituals. We'll see what are the components of this palliative care as such. The first and foremost component is the communication. Communication as such, it is important that we have to communicate about the condition of the baby. Like even breaking of bad news, we have many protocols, Spikes protocol, which we can follow, and it depends on the institutional policy to break the bad news about the child. And also in case of the condition of the child, permission for autopsy also may have to be sought from the parents, even during the diagnosis, during the phase only, so that it is done in a scientific and legal ethical aspects are all followed. Active listening to the family, to the parents is important. Give full opportunity for the parents to explain their concerns, their feelings, and also we have to communicate with them in a language that they understand, like medical jargons need not be used. And even the presence of the doctor and the healthcare professional, the nurse, makes a difference that helps them both physically and also emotionally. Uninterrupted time for the parents also help them to cope up and to express their concerns. Non-verbal gestures that we show during the conversations, like moving of the head, facial expression, all these make sense during this moment of grieving. And when we communicate, it is important that we communicate by referring the baby by name, and also what to expect about their child. It has to be clear, concise information has to be given, and options should be given to the family regarding the plan for disposal of the last remains of the baby, and no confusing language or false assurance should be given to the family. Then coming to the pain management as such, we use different pain scales to assess the pain of that is experienced by the newborn. We have to use also many measures like physical simulation, or if the parent is willing to massage the baby or use any type of things for the comfort of the baby, that has to be taken care of. Even like intragastric oral sucrose can be given, or pacifiers, so that the child is able to have a good quality of life is maintained. Then environment, when we consider, it is important that we respect the privacy of the parents. Often we know NICUs are all very much, it is a busy area wherein we have a lot of newborns. It would be ideal if we could offer some space for the parents and the family to be with the child, or even we can seek for the permission or their option whether to be with the child, whether they want their child to newborn to be in the active phase of dying in their home or in the NICU only. If they agree to take the baby home, we should permit that. And also at every point of time, it is important to involve the family in the decision making, and also like wristband, whatever they want, the religious methods or the religious rituals, what they want to perform has to be done. Like for example, Christians, they want the child to be baptized, and anyone can baptize the child. It is not necessarily the priest. In the religion, they give certain things which has to be kept in the bed of the baby, or they want to tie thread or something. When we are providing palliative care, we can allow all this so that they are also religiously the satisfaction, the rituals are performed, and the parents are satisfied. And parental activity like cuddling or being involved in the care of the baby or spending time with the baby are all need to be considered and given priority. The precious moments that they are going to spend with the child. If the mother is wanting to breastfeed her baby, we should allow the baby to be breastfed and massage the baby or give bath to the baby, change the diapers, involve actively in the care. And also memory makers, if the parents want to take any photo of the baby, we should allow that. And also to spend quality time or to take band, anything that is it, if they want to have it with them, that can also be facilitated so that they are able to make few memories of all the things that their baby had. And it is essential that during the phase of active dying and after death, the paperworks like informing the corporation, we have paperworks that are related, and that has to be done. And also transport, we have to consider transport of the body. These all can be prepared so that in consultation with the parents, so that the care is provided effectively. And I want to share this study. This is a study done in a Lofer Hospital. Okay, this is related to the neonatal palliative care that is provided in a tertiary hospital. Yeah, this is this is a new concept that was developed, and they had done this referring of around 1,800 babies. This is published in PubMed. They have found out the strength and the barriers for the neonatal palliative care
Ms.
team.
Cecilia, can we wrap up in 2 minutes?
Yeah, sure. Okay. Here they had a team of 2 doctors and 2 nurses, and they were doing it. The strengths that they found was like there was continuous support and encouragement from the senior leaders in their department. Being a teaching hospital, they were willing to talk, and they were also very curious, and it happened a lot. The team had adequate and appropriate physical space also, so that they were able to counsel and communicate with the family members. They also had follow-up visits for babies who came as outpatient also, and they were highly motivated. The NPC team was highly motivated and committed to ensuring the success of the programs. And also there was a steady source of funding from the local charitable foundation also. The weaknesses that they found was like palliative care was a relatively unknown concept in that hospital. So like reference, they were not aware whom to refer and whom not to refer. Then NICU clinicians had inadequate knowledge around opioids, their use in neonates and opioid myths. The NPC team also has not previously worked at the hospital, so that lagged. So on the job they were learning, there was significant learning and they adapted to the situation. And there was a situation like frequent rotation of residents and senior physicians at the hospital. That also repeated frequently, like awareness and advocacy training has to be repeated in those cases. So several things were found to be stressful and also difficulty in providing care to these dying babies. So, but they found this study to be feasible and they have advised for replicating the model in many other institutions. So to summarize as such, every newborn deserves care and concern as citizen of the country, and this is as per the constitution and the article. So care of the family is the central focus and the nurse is a consistent caregiver. Palliative care is an interdisciplinary endeavor. When the transition is made from curative to purely palliative efforts, the best results occur when the team is consensus and all should be informed. Whoever is in the team should be informed of what is the procedure and how we are going about it. So consensus includes decisions about appropriate treatment and also options for individual infants. So these are my references and thank you.
Thank you, Ms. Cecilia. It was a nice presentation on palliative care. Dr. Anu, any comments?
Yeah, thank you so much, Dr. Kavita, Meena, and Team NNF for having me on board. So I'll quickly summarize and make two important things. One thing is that the conditions in neonates are medically complex, and it is neonatal population is very unique in two aspects. Number one, that there is very little research on end-of-life assessment and management. There are many tools available for children, for adolescents, for adults, but there is nothing like a recognized tool for neonatal population. Nonetheless, we should understand that neonates also experience significant symptoms at the time of end of life. This may include pain, dyspnea, agitation, lot of secretions. So that means that for each and every neonate, one thing is that this has to be individualized. You cannot say that for 10 neonates you're doing this or for 20 neonates you are things. So first learning point here is it has to be individualized. Second thing is we don't have enough data to support what to do, where to do, and how to do. Nonetheless, the second thing, important thing, of life. That is all from my side, and thank you, Cecilia, for an elucidating presentation on palliative care. Thank you, Dr. Kavita.
Thank you, Dr. Anu. We'll move on to the next session. So next session is preventing infection and sepsis in the NICU, role of bundle care. So for this session, I would ask Ms. Meena to introduce the speaker. I'm not sure. So Ms. Meena is not online, but the speaker for this session, preventing sepsis in the NICU, is Ms. T. Tulifi. She's
Okay. Actually, I spoke and my this thing was mute. So let me introduce her. She is Tulip. She is from College of Nursing, AIMS, Jodhpur. And a very special thanks to Tulip because at last moment she accepted our invitation and she joined us. So thank you very much, Tulip, and welcome to the session.
Good evening, everyone.
Yeah.
Is it my slide visible?
Yes, yes. Just a
Yes,
minute, Tulip, I'll introduce the chairperson for your session. Is
Yes.
Dr. Pratima Anand. She's faculty in Lady Hardinge Medical College, New Delhi. And I think there is no nurse in the country who has not heard of Dr. Pratima because she's done so much of nurses training, preterm care package, NeoQuip. She is the leader of all those sessions. So welcome, Dr. Pratima. It's a pleasure to have you. Tulip, we can start.
Thank you. Yeah. You can begin. We'll comment later on. And happy to see you all together. Happy Nurses Day to all. Yeah, thank you.
Tulip, 10 minutes.
Okay. So the topic assigned to me is preventing sepsis in NICU, nurses as the backbone for the bundle care. So as we all know, sepsis is one of the most important causes of neonatal death in the hospital. So every hospital should have its own policy to prevent infection of newborn in their newborn areas. Healthcare providers tend to transmit organisms during routine procedures, so we should be very careful while handling the babies. Prevention of infection is more cost-effective than treating infection in neonates. There are certain principles which we need to follow in prevention of sepsis, which include maintaining standard precaution, hand hygiene, policy regarding visitors in NICU, basic asepsis routines, rational antibiotic policy, surveillance and nursing staff management, biomedical waste management, bundle approach for VAB and CLABSI, and finally, good housekeeping routine. We would not be able to go in details, but we'll just run out with some important points. So coming to asepsis basics, there are some basic requirements that is like in a neonatal intensive care unit, we should have a proper hand hygiene areas with a running water supply, soap, elbow or foot operated taps. Strict hand washing protocol should be there, and we should also avoid overcrowding of the people inside the units. Or we also should have an adequate number of staff nurse ratio. And we also should have a rational antibiotic policy in a written form. And also we should follow aseptic routine and housekeeping protocol. Other thing is guideline for entering to the babies. This is, as we all know, person with active infection should not be allowed. Like if the mothers or the caretakers are coming with a full sleeve, we should allow them to roll up the full sleeve up to the elbow. Put on new slippers, wash hand with soap and water for 60 seconds. That is, we have to instruct them to follow the WHO steps of hand washing. Put on sterile half sleeve gown. All these are the instructions we should give to the mothers or the caretakers who are visiting to the neonatal intensive care unit. Policy regarding visitors. And also we should strictly follow the sterile gloves. Always we should use a sterile gloves during invasive procedures. Adequate number of steriles and clean pairs of gloves should be available in the unit for if we want to proceed the aseptic procedure, we need to have all these articles. Other basics, it includes like change of IV set tubings for TB and daily or as per the set protocols. Change antiseptic solution in suction bottles as per the protocols, maintaining nursery environment clean and calm, and the floors should be clean with each shift or as per the unit protocol, it has to be followed. Clean walls with 2% bacillus once in each day or as per the unit protocol. Coming to the standard precaution refer to practice of avoiding with patient fluids by means of wearing personal protective equipments. This personal protective equipment, it is designed especially for doctor, nurses, and the healthcare workers who are in direct contact with the patient body fluid. So appropriate PPE should be worn as per the requirement. Coming to the hand hygiene, as we all know, hand hygiene is the single most important means of prevention nosocomial infection. It is very simple and cheap, and we can prevent lots of infections if we properly follow the hand hygiene technique. Hand washing norms, as we all know, 1 minute hand washing, 11 steps to be done before entering the unit, following the WHO steps of hand washing. Hand hygiene with alcohol hand rub for at least 20 to 30 seconds, following the 8 steps of WHO hand rub. So we know when we have to do hand hygiene, or we should educate the parents or the caregivers when they need to do the hand hygiene. According to WHO, there are 5 hand movements for hand hygiene. That is before touching a patient, before clean or aseptic procedure, after body fluid exposure, after touching a patient, or after touching patient's surrounding. So every one of us is well versed about this step of hand hygiene, so I'm not going in details of the step. Rationale for antibiotic policy, we should use antibiotic judiciously, avoid prolonged course for broad-spectrum antibiotics for to prevent further complication to the child. Surveillances, it is defined as monitoring of infection in the unit by conducting periodic survey in order to identify unusual pattern of flora and infection. It also includes monitoring of antibiotic use and resistance. Surveillance may be carried out, like, for example, room air in weekly basis, surface of warmer incubator weekly basis, equipments like ambu bag, masks weekly basis, liquid like water in the humidifier bottles twice weekly basis, baby's blood or CSF culture whenever it is indicated, pulse culture whenever present, personal hand, nasal, throat swabs as required. Next is safe disposal of hospital waste management. This is again, it is very important. Like we should safe disposal is very important to keep the environment clean and also to prevent infection from one person to another. We should be very careful while segregating the hospital waste product, because 85% of the waste product are not non-infectious and only 15% are infectious. So if we are mixing or without proper segregation, it can lead to many infections. Coming to practice Pandar approach, we have a VAB and CLABSI. VAB is defined as nosocomial infections, pneumonia in mechanically ventilated patient that develop more than 48 hours after initiation of mechanical ventilation. And CLABSI is a lab-confirmed bloodstream infection in a patient who had central line within 48 hours period before the development of bloodstream infection, and that is not related to an infection at the other site. Coming to the care bundle for VAB, it includes maintaining hand hygiene, aseptic precaution during suctioning, no routine use of saline during suctioning except if there is any deleterious or thick secretion, proper positioning of the infant, that is raise the head and 30-degree and lateral position to avoid aspiration, promote optimal humidification, promote Mansfield-Kurtz motility and microbial flora, use express breast milk with the mats. Next is care of Pandar for CLABSI. It includes, the Pandar includes again hand hygiene, ensure maximum barrier precaution, that is sterile gown, sterile gloves, surgical mask cap for insertion and assistant, disinfect skin as per the unit protocol, maintain sterile field throughout the procedure, use transparent dressing and change when contaminated with blood, and do not break the continuity of line for giving antibiotics. So coming to the last, good housekeeping. Each baby separate, there should be a belongings should be kept separately. For examples like spirit and pitatin swab container, stethoscope, inch tape, thermometer, resuscitation equipments, hand rub. There are many do and don'ts which we have to follow in good housekeeping, but I will not go in detail with this. So with this small quotation, I would like to conclude. An ounce of prevention is worth a pound of cure. It's given by Benjamin Franklin. Thank you.
Thank you, Ms. Tulip, for the crisp and timely presentation. Dr. Pratima?
Yeah, thank you. Thank you for the crisp presentation. I think just like we have warm chain and cold chain, I keep on saying that we should have an asepsis chain also, and the bundle begins right from the delivery room itself. So the bundle during resuscitation, including the asepsis routines in the labor room, during resuscitation, during transportation, and then finally into the entry till discharge. And of course, all the points were well covered. So, and no doubt that nurses are the backbone, because we have been learning from them the basics of asepsis while doing any procedure, be it sampling, intravenous cannulation, simple procedures, IV fluid preparation, medications, administration of medications, every step, every procedure inside NICU, handling of the baby, all these require strict asepsis, and most of the points were well. Thank you so much, Dr. Kavita, Meena ma'am, for giving me this opportunity, and happy Nurses Day again. Thank you.
Thank you, Dr. Patel. So we have finished all the 5 talks. So we're now going to move on to a very interesting panel discussion. And Dr. Poonam Joshi is the chairperson for the discussion. I would be the moderator. So Dr. Poonam, I would invite you to introduce the panelists for the session today.
Okay, thank you, Dr. Kavita. So now we move on to an interesting panel discussion. This panel discussion is about neonatal nursing in India, challenges faced and hopes for the future. And in this session, my co-chairperson is Dr. Bharti. And I take this opportunity to first of all introduce our moderator, Dr. Kavita, who has been with us throughout the day, throughout the evening during this session. So Dr. Kavita, she is an associate professor in Goa Medical College, and madam has been associated with NNF and has been part of various educational activities which NNF has been organizing time to time for the nurses. And she is currently holding the charge of secretary, NNF Goa chapter. And now coming to the panelists, we have a group of senior nurses, administrators, educators who are there with us. So we have Ms. Suma Nair. She's working as nursing supervisor in super speciality, Chetinath Healthcare City, Kelambakam. Then we have Ms. Suma Dabas, nursing tutor, College of Nursing, AIIMS, New Delhi. Ms. Hina Dabas, clinical instructor from Guru Tegh Bahadur Hospital. And Ms. Meenakshi Devi and Ms. Sneha Patil. Ms. Meenakshi is from SMGS Hospital, Jammu. And Ms. Sneha Patil is a senior staff nurse having 38 years of experience of working in NICU in KEM Hospital, Mumbai. So over to moderator, Dr. Kavita.
Thank you, Dr. Poonam, and welcome to all the panelists. So we will have to be really brief in our answers because, you know, we are mothers, nurses, doctors together, so our families are waiting for us. So in keeping with the theme of this year's International Nurses Day, that our nurses, our future, the economic power of health, a few questions are going to be, we'll ask you one by one. The panelists, I'm so glad have been selected so well by Dr. Surender and Ms. Meena. They represent the private as well as the government sector, and they have vast experience in neonatal nursing as well as neonatal nursing education. So my first question is to Ms. Suma. One is, do you think that being a neonatal nurse is different from other branches in terms of their roles and responsibilities? And would you say that it is preferable to have specialized training when a nurse goes into an NICU to work?
Good evening to all. First of all, Happy Nurses Day to all. I am from Chennai. I am Suma Nair from Chennai. I am working as a nursing supervisor in NICU for past 18 years. I worked in abroad also before, now 7 years in Chennai. I express my sincere gratitude to thank enough to giving me this opportunity, especially for Dr. Giridhar Seduraman to suggest me for this session. Actually, my question is for neonatal nurses different from other branches in terms of roles and responsibilities. Yes, of course, neonatal nurses needs extra responsibility to take care of neonatal. They need extra training to take care of the babies, those who are preterms or sick newborns. Preterms are delivered before the expected date of delivery, and they need special care as mother's womb. What we are getting from mother's womb, we are the persons to provide care to the babies, like provide warmth, atmosphere for gently handling skin care, and minimizing the sensory stimulation. And that is the responsibility of a neonatal nurse. By witnessing of struggling newborns like respiratory distress, babies are having respiratory distress, congenital anomalies, if their prognosis is good or bad, we have to give emotional support to the parents. That is also a big role of neonatal nurse, because they are spending most of the time with the babies and parents rather than doctors. Then other component is both the parents and babies are emotionally strained during this situation. They are separated from parents, they are separated from families. They don't know what is going to be we are going to do with the babies, and we should be very aware of the disease conditions. We should have the trained nurses in NICU. Neonatal nurses should have the skill and knowledge of all the advanced procedures, equipments, and the new technologies in NICU. This helps to prevent the high risk of the neurodevelopmental of the newborns. I think neonatal nurses takes big roles in the NICU as well as clinically as well as emotionally, because that's why they are different from other branches of nursing.
Right. Thanks, Ms. Suma. So we know that it's not the same. Taking care of a newborn is not the same as taking care of an adult, and we definitely need better training, a different type of a training to be a neonatal nurse. My next question is to Miss Sneha. So you have worked for so long in like how Dr. Poonam has said, almost 30 plus years in the NICU. So over the years,
No,
have you seen
13th year, not 38 years.
Okay.
3.
Okay. So what do you think are some of the changes that have happened in terms of challenges as well as the developments over the years in neonatal nursing, like from beginning to current scenario?
First of all, good evening, one and all present over here, and happy Nurses Day to all nurses, and happy Mother's Day to all mothers. I would like to say a few lines about nurses. A nurse is one who opens the eyes of a newborn and gently closes eyes at a dying man. It is indeed a huge blessing to be the first and last to witness the beginning and end of the life. So, coming to my question. Now, since NNF and Government of India organize various facilitated newborn care programs over the last few years, because of this program, neonatal nurses have seen significant advancement over all the years. Challenges like preterm birth, congenital disorders, and complex medical conditions have been met with developments such as improved technology for monitoring and treatment, specialized care technique, and increased emphasis on family care center. Involvement of mother in baby's care, better higher KMC care, it gives baby can get early discharges, better golden hour management. We have transport incubator, so it prevents hypothermia, giving blended humidified oxygen, which improves preterm neonatal outcome. Try to mobilize mother means as soon as baby born. And if baby is NBM, we are also giving colostrum to babies on orally or kept on lips. The field continues to involve ongoing research, enhance education for nurses. Because of less nursing staff, there is a less nursing ratio. For intact survival and for better survival, we need better nurses and patient ratio. Thank you.
Thank you, Ms. Sneha. So basically, one is the most challenging thing what has happened over the years is more and more smaller babies are being taken care of in the NICU. More preterm births are happening, and new technologies are coming over the years. But the most recent things which are new are, one is family integrated care is being emphasized, KMC is being emphasized, and mother's milk is being emphasized. So, thank you. My next question is to Ms. Meenakshi, who is working in Jammu and Kashmir. So what are some of the most pressing challenges faced by neonatal nurses today in today's healthcare environment while working inside the NICU? And do you think these challenges actually impact the care that we provide to the newborns and their families?
Thank you, ma'am. Thank you for giving me such a wonderful opportunity. Ma'am, for my question, we are facing a lot of problems, a lot of challenges in our ICU. If I talk about my NICU, ma'am, we are facing two most important challenges. First is shortage of staff, and the second one is ma'am overcrowding. Like अगर मैं अपने ICU की बात करूं मैम, तो we have more than one baby in a single warmer, ma'am, which causes lot of problems, and स्टाफ के लिए बहुत मुश्किल रहता है मैम, क्योंकि हर बेबी की जो रिक्वायरमेंट है वो अलग है. if one baby is hypothermic, another is normothermic, then how can it possible ki we manage two babies of different requirement in a single environment? That is one of the most important challenge we face in our NICU. And naturally, ma'am, when we are facing overcrowding and lack of staff, then it impacts on healthcare system, because जब हमारे पास इतना ज्यादा crowd होता है, मैम, हम कोशिश करते हैं अपना 100% we provide care, but we are not able to provide a quality care, ma'am. So I think it is the impact on the healthcare कि हम वो quality care कहीं ना कहीं अपनी तरफ से पूरी कोशिश करते हैं, but मैम कहीं ना कुछ कमी रह जाती है, मैम.
Yes, thank you, Ms. Meenakshi. I think that is a problem we all are facing of less staff. But I can assure you that you all are the most dedicated group of nurses that we have worked with. And ho raha hai. I think people are now, since this theme has come up, people are going to realize that investing in more number of nurses is going to actually save lives than not. So thank you, Ms. Meenakshi. My next question would be to Ms. Suman Dabas. So do you think like advancements in technologies, like in terms of equipment or interventions, will offer some solution to these challenges, like this when there are more number of babies? And how do you think they will assist the nurses in caring for a sick newborn? Suman, you're muted.
Thank you so much, ma'am, for providing this opportunity, and happy Nurses Day to all of you. So for the question, definitely yes. Advancement in the technology and like interventions offer some solutions to the nurses, those who are working in neonatal ICU, like many technological changes, like multipara monitor, like earlier multipara monitor were not there, so it was difficult to take the BP and other vitals for the baby. It require lots of time, and nowadays in the multipara monitor we have all the readings, and in the ventilator tubing, earlier it was difficult task to prepare the tubes, but now we have ready-made tubings and advanced phototherapy blankets. They used to save lots of time. And like video assisted laryngoscope is also there, so it will decrease the difficulty in the resuscitation. Ready to use tubings, and TP resuscitator, Billy blankets, and like most advanced like incubators. Earlier we used to take weight in the weighing machine, but nowadays incubator are there, so less handling, and it will require less work, less efforts. Like we can automatically take the weighing. Otherwise it was a Herculean task in the morning to take the weight of the neonate. So it reduces the efforts, but now the AI is also emerging, like artificial intelligence is also emerging, so it will decrease, diagnosis will become easy, and calculation will become easy, but the expertise skills or the intuitive skills that a staff acquire over a period of time, so that is not at all replaceable in any circumstances. Other it can enhance the efficacy, but this skillful nurse and a motivated nurse is not replaceable. So
yeah, excellent point, Suman. That the nurse's eyes, ears, and hands, no one can replace that. What a nurse sees in a baby and what is going wrong, nothing can replace it. But yes, some technologies like pulse oximeters, multiparas, disposable, consumable items, all these things make it a little easier. My next question is to Miss Hina. So especially now, हम लोग मांगते हैं सब monitors वगैरह, but in resource limited settings, what are some of the things a neonatal nurse can do which can impact the health of the neonate and families, especially in where you do not have enough number of resources? What are some of the things we can start doing from tomorrow?
Good evening, everyone. Happy Nurses Day to all. Thank you, ma'am, for your questions. And I would like to express my sincere gratitude to Meena Joshi, ma'am, for giving me this opportunity. Ma'am, from research limited setting, first and foremost thing that is the promotion of hand hygiene. That is the first and foremost basic step. And second is the infection control policies. The parents who are entering in the ICU, how they have to wash their hands, how do they have to enter an ICU, what are the things they have to take care to reduce the infection, promotion of breastfeeding. Then aseptic techniques has to be followed during the procedures. Maternal health education regarding how to take care of their babies, how to change the diaper, how to take care of food and other aspects has to be taken care. If involvement of KMC, birth spacing and these aspects has to be taken care of. And when they have to come for postnatal visit, what are the immediate danger signs? How to identify the danger sign, and when they have to immediately report to the hospitals. And as resource limited settings, as one of the point can be, there can be staff shortage also. So in the family integrated care has to be has an important role in this development and supportive care. And bundle approach is one of the major phenomena which can reduce the infant mortality also. Then along with this, ma'am, there should be training of nurses. Simulation-based training has an important role that before practicing on these newborns, there has to be practice on dummies, online training sessions or offline training sessions. Induction training has to be taken care of before they are working in the NICU. And QI initiative programs has to be launched for identify the lacuna in the system. These are the few of the points, ma'am. This can improve the infant outcomes in the resource limited settings.
Excellent, Hina. Those are the most relevant points. If we start doing that, we will in fact reduce the days that the baby remains with us. So all our work, everything comes down. Excellent. My next question is to Ms. Suma. So it is known that neonatal nurses, we experience a lot of emotional fatigue and burnout while working in the NICU. Jaise abhi Meenakshi was saying, how to take care of 2 babies. You need to give optimal care. You're not able to give optimal care. So this can lead to a lot of emotional fatigue. So how you think a neonatal nurse can handle this in a better way? And also, do you think that there is like an inequality with respect to socioeconomic status that leads to, contributes to distress among nurses?
Yes. These situations I divide into 3 points. That is nursing related. One is nursing related that we described above as shortage of staff, enough staffs. Shortage of staffs. Most of the hospitals, they don't have enough staffs according to the patient ratio. That is one of the nursing related reason. Other is infant related, baby related, newborn related. Actually, we working with untrained nurses, and if some emergency comes, the senior nurse has to take all the responsibility, and they are getting the blame for everything. They are getting the criticizing condition. They are getting the distressing with others. This affects the proper nursing care. Because it is induced that it is common reasons actually. Untrained nurses coming to NICU without any proper training means they don't know the equipment, how to handle the emergency situations. That is the stress for senior staff nurse. Then they are only staff related because they have to work more time. Sometimes some staffs are suddenly getting sick. They have to continue their duty 2 shifts or 3 shifts. That affect their family situation. Some are feeding mothers, some pregnant women will be there, some single mothers will be there for job. Then they will affect their families. And so the second part of the question is the respect to social economic status. Definitely, nurses are from the nurses are from lower or middle class family. No, most of them are lower or middle class family. They are forced to do duties with less salaries. I think India, according to other countries, India is the Indian nurses are getting the least payment for their work. They are not getting the extra payments for their overtimes, their extra duties. They are not getting the incentives. They are not getting the adequate concessions for the duties they are doing. Thank you, ma'am.
Thanks, Ms. Suma. I think sad but true. So and I think this is the first time I am hearing about that our nurses are getting paid the least in India. So 2 good points. It is creating burnout, and one of the things, knowledge is power. So if you know what you're doing, that is going to lead to less stress. Thank you for those inputs. Ms.
Thank you.
Neha, my next question is to you. Since you have been working in the NICU, are you happy with the amount of involvement that nurses are having in treatment decisions? Usually,
ma'am.
we as doctors also, we see that we tell what is to be done, but we do not involve the nurses so much. So you think nurses should be actively involved in taking treatment decisions of the baby and also in counseling the parents?
Yes, ma'am. Actually, nursing's involvement is increased all the times over last few years, but it is not in all the centers. So we are required more involvement and more training to the nurses. Nurses involvement is treatment decision needs to be increased, as we nurse, we only one person who spent more time with the baby, and that we are able to understand baby's needs better and also train the conditions of the baby can be judged by the nurse during their vital chartings. Means when we are charting vitals, we only knows what baby needs. So when to give feed or when to start KMC, they can involve a nurse too in that program. Provide more and long-term KMC, like at the daytime, we can give KMC to mother or caretaker. But we are started at the night time also. We allowed fathers to take KMC at night times. Because mother दिन में मदर थक जाते हैं मैम, so night में, और फादर means their bonding also so good. फादर उनको इतना अच्छा ये होता है फीलिंग्स when we are taking meeting with them, तो उनका एक्सपीरियंस बहुत अच्छा रहता है कि मीन्स हमारे बेबी को हमने लिया करके. और we have started KMC with CPAP and ventilator babies also.
और आपको लगता है जब डॉक्टर्स पेशेंट को काउंसलिंग करते हैं, आपको लगता है कि नर्सेस को आना चाहिए हमारे साथ?
यस यस,
हम यूजुअली नहीं लेते नर्सेस को, आपको लगता है नर्सेस शुड बी इन्वॉल्वड इन काउंसलिंग ऑफ?
या
thanks Ms. Neha.
One thing, formal counseling session with parents can help them understanding their child's condition, treatment options, and share decision making between healthcare providers and families. This approach promotes holistic care and enhance patients' outcome, ma'am.
Right, I agree. Thank you.
And last, palliative care. So also we involve palliative nursing care, counseling for a very sick baby. We also started in our NICU that palliative newborn care program. They are taking so much efforts for that.
So moving on to the next question to Ms. Suman. So now, since you are a nursing faculty for nursing, do you think there has to be some changes made in the undergrad curriculum for nursing so that they are more prepared to take care of neonates? Do you think the undergraduate curriculum is in favor of neonatal nursing, or do you think it needs to be changed?
So some of the aspect it is incorporated, like newborn care is a unit for the newborn care is included in the syllabus. But like incorporation of the ENBC, essential newborn care modules in the nursing curriculum can be added, like 10 modules that we have, they can be added in the curriculum. And education of the common equipments and the common procedure that we are doing in the neonatal ICU, they can be taught in the classroom. And neonatal resuscitation and more focus on the hands-on training, and simulation-based education should be incorporated, and importance of the closed loop communication should be taught in the beginning of the third year or the fourth year. And this type of education should be given before the posting in the neonatal ICU. And 2 or 3 students can be posted, because more student cannot be posted because it will increase the risk of infection. So 2 or 3 students can be posted at a time, and group discussion among them for the care they are providing. It will enhance their understanding. And for the parents, we can how to counseling, and role play can be incorporated, like how they will counsel the parents, what is the psychological state of the parents when they are facing the premature delivery. So role play can be incorporated for the counseling of the parents.
Thank you. So basically more hands-on training during sessions and more teaching on how to communicate with parents. Yes.
And the research for the care, like research should be included for the students so that like they can, when they will be nursing officer, they can give better care and evidence-based care. We should be sensitized about the evidence-based, what is evidence-based care. So when they will be posted, they will provide evidence-based care practices. And like some of the research area, like what is the more effective, like relaxation technique, or the massage, or the touch of the mother, sounds of the mother, which one is more, like these are the some initial
So there is a
topics.
lot of scope for research also in neonatal nursing.
AI projects should be started.
Right. So Miss Meenakshi, this is my second last question. So since you from the hospital administration economic point of view, what would be the steps you want the stakeholders? Abhi agar you are part of a committee which decide what needs to be changed in terms of neonatal nursing care and also well-being of the nurses themselves. So what steps, one or two things you will ask them to do? And do you think a higher investment nursing sector will ultimately lead to better economic structure of that hospital or organization?
Yes, thank you, ma'am. Ma'am, from hospital administration and our stakeholders, the first point I want that training and education, ma'am, proper, regular, and second point, ma'am, as a ma'am said earlier, competitive compensation in the form of salaries and incentives. Because ma'am, nurses working in the NICU is totally different from the nurses working in the light wards. So there should be incentive or maybe not in the form of money, ma'am. There should be appreciation tokens for the sisters working in the NICU, ma'am. And ma'am, works for sport, for for emotional support of the sisters working in the NICUs. These are the something we want from the education. And naturally, ma'am, if we are investing on the nursing care, तो इससे तो मैम एक तो ये होगा कि अगर हम इन्वेस्टिंग इस पे करेंगे, नर्सिंग एजुकेशन और ट्रेनिंग पे करेंगे, तो उससे मैम जो हमारा हेल्थ केयर कॉस्ट है वो हमारा कम हो जाएगा। और प्लस अगर हम ट्रेनिंग एनहांस करते हैं तो हमारा जो वर्क फोर्स है वो एक ट्रेन्ड नर्स के रूप में आएगा और हमारा हेल्थ केयर सिस्टम जो है वो इकोनॉमिक स्ट्रक्चर भी उसका जो है वो अपग्रेड होगा, एक ऑर्गेनाइजेशन का और एक्चुअली कंट्री का भी। मैम
Thanks. Very correct, Meenakshi, that if you invest in nurses training and number of nurses and their well-being, I think it's going to reduce the cost of neonatal care. Hina, my next question is to you. So, NNF is doing a lot of training, nursing education, INN also is doing. But anything else you think as these bodies, private bodies, do you have like any sort of request or, inputs to these bodies like NNF and INN?
Yes, ma'am. There can be launch of some fellowship programs or nurse practitioner courses to upliftment and also to motivate nurses for the higher education and implementation of STP. There should be development and implementation of STP all over the India for the improvement of neonatal care. Nurse-led clinic has to be taken care of for so that they can follow up the baby after discharge, and they should have their role in the decision making also, not the submission role only. And improve simulation brain trainings and hands-on sessions should be more. And the last point is, as ma'am has rightly mentioned, incentive has to be given. There can be employee of the month, also appreciation token in some sort of. These are the few of the sources, ma'am, which can help in this.
Right, I agree. Like NNF gives a fellowship of an award to doctors. I think we should NNF should
yes, ma'am.
Should start like a best nurse or over the country. We should. So yeah, incentives and excellent points. So that is my formal questions are done. But I would like to ask one point to each of the 5 panelists, one point each. So what a lot of stress and a lot of problems are brought out. But do you see a positive change happening in terms of neonatal nursing in our country? We'll start with Suma. Give me one point where you think, okay, this is going to be good for us.
Yeah, actually, online training is more than previously. No online trainings for nurses actually.
So
after
online
COVID,
training.
after COVID break, it is an online program that is more helpful for nurses because they can't attend the physical meetings we are conducting. All nurses can't attend at a time.
Right.
And this online.
Suma, we'll move on. Miss Neha, you think anything? Tell us some good positive point to end the session.
Yes, ma'am. Actually, we have small celebration for occasions and achievements, and celebrate it together. Means
Right.
when
So
we are doing some.
you have already started. We also should start celebrating our nurses. Very good. So this session is also celebrating nurses, neonatal nurses. Yeah, Meenakshi. Suman, one positive point for future.
So induction program, like if any new nurses is appointed in neonatal ICU, induction program and simulation based education should be incorporated, so they will be able to provide better.
So many
nursing.
institutes have started induction programs. Yes, Hina.
Ma'am, I have seen the shift change. That is earlier that if somebody has done masters in medical, surgical, or in other specialty, they used to be posted in NICU. Now the preference has to be given to those who have done masters at least in pediatrics, MSc pediatrics. They are posted in NICU. So this is the major changes which has been followed in tertiary centers, tertiary care center, but still this has not been much applied to state government hospitals. So this is the one of the major change, ma'am, what I have observed.
होने लगा है, शुरू हुआ है, which is
हाँ
good. So I think that brings us to the end of an interesting panel discussion. Dr. Poonam, your final comments, and then we can end the.
Yeah, thank you, Dr. Kavita. It was wonderful to listen to our panelists. So I would like to just summarize the few important points which have come out of this panel discussion. So as one of the panelists said, that manpower shortage is a burning issue. Definitely administration will look into it and will try to convey your issues to the administration so that the problem of manpower can be sorted out. And as Suman said, there is no substitute to technology. I should say other way around. There is no substitute to human care. Technology is there to help us, to support us in facilitating the newborn care. So too much of dependence on technology is not good. We have to continue giving our personal observation. Close clinical observations are very much essential. Then third important point which has come out of this discussion is adhering to the infection control practices. Next is empowering the family members, mothers, and encouraging them to be the part of newborn care. And then giving due recognition and appropriate remuneration, appreciation is something needed for the nurses. And their qualification should be given due importance as pointed out by Ms. Hina. So definitely I fully agree with you that this is something to be incorporated. Having nurse-led clinic is something which we are looking forward to. And finally, I would like to say that neonatal nursing is evolving as a specialty and a lot is needed to be done. We need to prepare our student nurses, especially the nurses who are there in the clinical area, giving them in-service education periodically so that quality care can be enhanced and improved. Thank you. So over to my co-chairperson and finally to Dr. Kavita.
Thank you, Dr. Poonam, for summarizing it so well. So Dr. Bharti had to leave early, the other chairperson. I would now invite Madam Parul Datta to give the final vote of thanks. So from my side, thank you for making me part. It was an interesting session, even though it was long, but the amount of work that neonatal nurses do, I think this much time we deserve and to give you. Parul Datta, ma'am.
Thank you. I'm audible, I think. Yes, I'm audible.
Yes, ma'am. Yes.
Yes, sir. Okay. Very good evening to everyone. It was an interesting session. and Happy Nurses Day to all the participants and speakers and everyone present here. And it's my proud privilege to convey vote of thanks to all the persons all involved in this program. So first of all, many thanks to National Neonatology Forum, its President Dr. Sushma Nangia, Secretary Dr. Surinder Singh Bist, Treasurer Dr. Amit Upadhyay, and our nursing representative of Executive Board Member, Ms. Meena Joshi, for organizing and celebrating International Nurses Day, emphasizing with the theme that our nurses, our future, and economic power of our care. And neonatal nurses, I think they are taking care of the future citizen of our country and of the world. So it is the nurse's hand. So we have to emphasize our hands, and especially in all respect, then only our economic power of care will be enhanced. So throughout the discussion, it was emphasized. And special thanks to Dr. Ashok Deurari for her presence and as a motivational leader. So many thanks to Dr. Deurari. He spent some time with us. And another, the important person is for this program is Dr. Kavita Srikumar, and she spent, I think, more than 3 hours for this program. She is having special involvement with the nurses, I think, and she also thinks along with other members, leaders, to improve the neonatal nursing practice in our country. I think in future we will be able to achieve that. Special thanks to Dr. Pratima Anand, Dr. Onu Sachdev, Dr. Poonam Joshi, Dr. Bharti Balachandar for their gracious presence as a chairperson for this session and to enrich with their comments. My heartfelt thanks to all young, energetic speakers for their important and relevant sharing of information to improve the neonatal nursing care practice, and that will ultimately help to reduce the neonatal mortality and the neonatal morbidity, and for the survival of the neonates as an intact survival, and to reduce the neonatal mortality by 2030 in a single digit number in our country. I think all the young energetic neonatal nurses, those are practicing or those are teaching, they are all fascinating, and they are all emotional to provide care for the newborns, our future citizen. And I think they will all do better for their activities and their performance. And my special thanks also to all the participants who have joined during this program of today for last 3 hours approximately, and also our digital partner, that Clarinet, who have given this online platform for this program. Thank you all once again. Namaste. I think have a good day, good night. I think enjoy everyone, and be passionate and emotional, not only with IQ, involve your moral quotient and emotional quotient for the care of newborns, and contribute as a neonatal nurse for our newborns. Thank you very much. Namaste.
Thank you. Thank you, everyone. Good night.
Good night.
Thank you, Kavita.
Thank you, everyone. Thank you, everyone.